AMD patient. And mostly they're asymptomatic or slight blurring of vision. So what you are noticing is either drusen or retinal pigment epithelial changes you are noticing there. And we also know that hypoxia and inflammation are the contributing factor, and with the passage of time, our RPE pumps are not functioning properly, and at that time we start getting the problem. And vision loss is related to atrophy in dry AMD. Wet AMD accounts for 10 to 15%, but it is responsible for severe visual loss in 80% of the patients. So that's quite a lot. And it reduces the vision significantly, coming up to counting fingers. And it can progress rapidly. In 3 months' time, you can have a significant visual loss. And untreated, high proportion of the patients will become functionally blind within 2 years. So that again is quite a lot. If you don't treat the patient or you delay the treatment, they are going to get blind. And once the scar is formed, it's not going to help them. And another factor is that over the 5 years, if you look around, 42% of the patients will develop CNV in their fellow eye. So they are going to develop wet AMD in other eye. So risk factors we all are aware of. Age is the main risk factor. Female gender is the second, most probably because they have got the older ages. Family history is important. Only preventable factor is smoking. So smoking really increases the risk twice. So if you are not smoking or you stop smoking, it's going to make a difference. Diet contributes to a significant extent. If you are having healthy diet, more fruits, vegetable, you're going to have less chances. Comorbids can indirectly affect it. Cardiovascular factors, hypertension can affect it. And again, UV light exposure, that has also been contributed in it. So preventive approaches, as we talked about, smoking can be stopped, have fresh vegetables and fruits that can help. Regular exercise, you can have low-fat diets and control your cholesterol, wear sunglasses for UV protection, and even ARIDS formulation that has shown that it can delay the progression in some population studies. So what are the investigations? So most common investigation, OCT, optical coherence tomograph, is the one of the main investigation. Second important thing is OCTA, so angiography, which is non-invasive, so OCT is really important. FFA, yes, I think still it's important. We need to do it in the cases, or at least in some cases for the first time if you're confusing between or your OCT hasn't given you much better picture. ICG in selected cases, especially in the polyps, you can think about using IC. Fundus autofluorescence, mostly it's for geographical atrophy or dry AMD. That's going to help you to give idea. So symptom-wise, vision can be decreased significantly. So we can have reduced vision. We can have contrast sensitivity can be reduced, metamorphopsia, or even central scotoma. If you're looking directly at something, you can't see it. So vision-wise, if the vision is 6 by 9.5, that means you can't read. It becomes difficult to read. 612 vision, your driving gets affected. And most of the country, they have got the driving standards. You're not legally allowed to drive, your vision is below that. 648, you can't recognize the faces. And 3 by 60, you are legally blind. Although you can see, but actually you're considered as a blind and you can apply for the benefits. So coming to choroidal neovascularization, I think still it's important to know about the classification. Is it type 1, type 2, type 3, type 4, what classification it is? So type 1 means that it's sub-RPE new vessels are formed here. So you may see hemorrhages here, but not clearly. But when you do fluorescent angiogram, you're not seeing typical lacy pattern, but you're seeing hyperfluorescence areas, multiple, patchy hyperfluorescence or stippled hyperfluorescence. And at the later stages, it keeps on increasing in that area. And even on OCT, you can clearly see that new vessel is beneath the retinal pigment epithelium. So you can make up about curled classic, even looking at the OCT. You don't need to do fluorescent angiogram. So here we can see that it's sub-RPE. Type 2, more hemorrhages, you would see clearly a greenish hue you can see there. So that gives you a membrane you can see better. And that's a typical lacy pattern of classic. Initially, you start seeing this lacy pattern and later the leakage will increase and just fill all over that area. And similarly in the OCT, you can see it's a subretinal new vessels that has developed there, so you can make it up here. So OCT is really revolutionized our treatment strategies now, because now we are not requiring FFA in most of our wet AMD cases. So we can clearly see in the outer retina there is a choroidal neovascular membrane, and you can see clearly from choriocapillaris it's coming up there. So other benefit is that you can see the leakage, and if you are doing a FFA, you can see the leakage, but on the OCTA, you will just see the lacy pattern. So especially it's good for like in proliferative diabetic retinopathy cases, you can see the lacy network, you won't be having any leakage to distort your image. Retinal angiomatous proliferation, that's again important condition, and I think the reason for recognizing this condition because your treatment varies. In some conditions, you will require more injection, in some you are requiring less injections, and some you require to have associated treatment. So it's really important to know your pathology. So here basically the problem starts from the retina. From the retinal new vessels, retinal vessels, they are anastomosed with each other, and they start penetrating deeper into the retina, or they can even invade the choroid. So it's type RAP lesion have got type 1, type 2, type 3 lesion. So here we can see that here they are forming anastomosis, and the problem starts, and you may see the hemorrhage, retinal hemorrhage when you look directly. And even here you can clearly see comparison between the OCTA and FFA. You can see here the leakage, and here you can see that where the neovascularization is getting formed. Similarly, choroidal vasculopathy, it's again important. It used to be said that it's more common in African and Japanese, but it's common all over, so you have to keep that in mind. And in such cases, you need to look for the polyp. You can see at the OCT as well, just beneath retinal pigmented epithelium, you start seeing the polyp. Or even when you do OCTA, you can see the hyperflow area surrounded by hypointense area. So that gives you a clue that it's a polyp. And if you're still not sure, you can go for the ICJ. So variety of anti-VEGF. So I haven't mentioned biosimilars here, but even the licensed treatments, they are quite a lot. So it's quite a lot range which is available. So briefly just touch bevacizumab, as we know that it acts as a VEGF-A receptor blockade. And ranibizumab is the small fragment in comparison to a whole antibody, which is bevacizumab, and that also binds the VEGF-A factors and blocks the receptors. Aflibercept, as we were previously talking, so it has got a dual mechanism. It's affecting VEGF as well and placental growth factors 1, 2. It's also gets affected, and it doesn't allow them to bind to the endothelium and cause angiogenesis. Brolucizumab, that again it's a modified fragment, you can see here, and that blocks the VEGF-A. Faricimab, which is the recent one for a couple of years now, that again has got a dual mechanism. It blocks VEGF-A and it has got angiopoietin 2 block it as well. So the difference can be seen here, but the main difference is the duration. So ranibizumab, as we talked earlier, it's around 34 days. Aflibercept acts up to 71 to 75 days. Bevacizumab, again, it's around 1 month. Faricimab, the good thing is about that it's up to 16 weeks, its action remain there. So it's a good news for the patients, initially loading doses, and then you can move to the longer duration. And brolucizumab, you can have effect up to 12 weeks. So that's a difference. So that's why it's important to know about. Coming to the response of anti-VEGF, I think this is the main important slide of my presentation. So if you look here, responsive lesions, 3-4 injections, just 10 to 15% of the patients. So most of the patients, they require injections. So I've got like patient, I'm in Pakistan for 10 years, I'm still injecting those patients. They're maintaining 6/6 vision, they're maintaining 6/9 vision. The problem is that if you stop the injection in those cases, or even you delay that, you can start seeing the leakage starts coming back in those cases. Or there are non-responders which are 10 to 15%. So you have to keep that in mind. A dosing regime, you can go for monthly injections, a bi-monthly, PRN as we were talking about, treat and extend. So monthly is quite expensive. So initially loading doses you can give, but it will be a big problem if you keep injecting like 12 injections in a year. It's quite a lot cost to the patient. Bi-monthly again for Eylea, it's a wonderful 3 loading, then you can move to that. PRN, again, you can, but the problem is that sometimes if the patient doesn't come or come later to that because patient thinks that it's been cured, actually it's not cured, that disease, new vessels are still there and they can leak anytime. Treat extend is a good option. You start extending 1 to 2 weeks, so usually 2 weeks duration you can start extending and keep it that level. And the benefit is that their visit will be reduced as well, and it's cost effective for them. There are certain safety concerns, especially uveitis and vasculitis, and brolucizumab was quite notorious in recent past. It can happen with any anti-VEGF. All can cause vasculitis, all can cause uveitis. But somehow, slightly the risk is higher in brolucizumab. That's why people are cautious in using it, and it's not as popular as other anti-VEGF agents.
I think they've called off. वापस ले लिया।
No, still, I'm using it in Pakistan.
It's not.
I'm using it in Pakistan. So it's not called. I think they वो safety concerns का मैंने कहा था, but it's not. But problem is that you can't predict किस patient में तो only people are using in the cases where other are not
2
responding.
weeks back, रोश वालों की बीमारी थी, February में, उन्होंने कहा कि हमने ये वापस मंगवा ली।
नहीं मैं अभी next week भी लगा रहा हूँ patient. It's not.
नहीं ये तो नोटिस किया है।
रोश वालों की
रोश की नहीं नोटिस की सही कह रहे हैं।
वो दूसरी है वेबिस्मो है that is वेबिस्मो
वो तो अभी तो लॉन्च हो
रोश की है
Vabysmo is better than, and that's why people are moving to कि वो बेहतर है कि 16 weeks भी है ना, तो इसीलिए एक तो ड्रॉबैक इनको ब्रोलिसिज्म को ये भी हुआ ना कि वो 12 weeks तक थी, यूफ्रेसिमेब वाज बेटर, उसमें उतना वो केसेस कभी नहीं आए। सिस्टेमिक वी ऑल नो स्ट्रोक, हार्ट की इश्यूज हो सकते हैं, वी हैव टू कीप इन माइंड। जियोग्राफिकल एट्रोफी, सेमिनार कैट एंड एवन में जब आया था कि काफी एट्रोफी, if you keep on repeatedly injecting that's the risk there as well. So I think I'll quickly come to the cases. So this is 74-year-old male with classic CMV. Vision was 636, and you can see CMV here is subretinal fluid, intraretinal edema, and retinal thickness was increased as well. So 3 monthly Lucentis were given. So now the scar has formed. The problem is that the longer the new vessels are there, although I have treated it, but because it was duration was a longer time, scar gets formed there. Kept on monthly until I had a complete dry macula, so that's really important. You want to have complete dry macula there. So then what happened? The fluids start coming back again after a few Lucentis injections. So that time I basically moved to Eylea because Eylea has come up at that time. And Eylea makes a tiny pocket, otherwise the patient was maintaining 612 vision. Look at the scar. And the vision is 612. So yes, contrast that thing is very good, but this patient has a problem with the other eye as well. So 612 is pretty good vision in spite of the scar. So you have to look for, so in wet AMD, even if the scar formation, vision is good, you need to give a try to the patient. And you try to maintain a good vision. That's another patient who had occurred CNV, 69-year-old, vision was 6/24. So very large PEDs, subretinal fluid, intraretinal edema you can see here, sub-RP fluid there as well, and that all area was involved. And in this patient has got other eye involvement, which I will show later as well. So initially 3 monthly Lucentis injections were given. So some fluid was reduced, and then after the injections, it's completely gone, the fluid there. But that doesn't mean that new vessels are gone. So later, fluid came up again, so we switched to Eylea. So 3 monthly injections were given, and that kept dry as well. We moved to the bi-monthly, we went to the injections, 6/9 vision was maintained. So look at that, how large CMV is here. So that's the outer retina, that's the choriocapillae. So very large lacy network, so that's all involving it. But the vision is 6/9, imagine, and his other eye vision is around 6/9 as well. So this is the other eye of the patient. Even you can see here is a large CNV there, intraretinal edema. So in this eye, when I was treating with the Lucentis, then we moved to the Eylea. So now the response was not coming to all of them. So that was the time when I switched to brolucizumab. I think it's a couple of years. So we were amongst the first of in Pakistan who used brolucizumab at that time. With the caution, we were careful as well, क्योंकि इतना hype हर जगह create की हुई थी problem, but there was no response. We told the patient. So that was appearance before injection. So that was the other eye, left eye. So you can see completely dry eye in the right eye. So then what after 3 loading, we moved to the 11 weekly. So still the patient is having 11 weekly injection. I'm waiting for Fresimab to come up. Once it will come up, I may move to that one. But otherwise, the macula is completely dry. Even the other eye as well.
Dr. Saab, can I ask a question? Sorry for the
Sure,
interruption.
no problem.
This is not my field. Do you think it's also important to check the near vision and document it? Because I have noticed that these patients have problem in central vision and reading Quran.
Yes.
So, and I always advise them to have a small amsler grid to educate
Yeah.
it, to follow it.
Absolutely,
So
because
near vision I also
it is
check it.
important. An amsler chart you can give to the patient and they can.
And I advise them then glasses with prisms or low vision devices for the
Yeah,
ear.
you can do that. So this is a relatively young patient, but again, wet macular degeneration patient. That's her bad eye, the right eye scar is formed. Here even you can see and now she presented with a problem in other eye, the good eye. So you can see that multiple PEDs here, there is CNV there, formed there, and we treated this eye with investment. So 3 monthly bevacizumab given, and then we increased, treat and extend interval. So she kept dry, vision is maintained at sector. She is a nurse basically, 6-12 vision she is maintaining. And now we have moved to 8 weekly investment. So you can go, you can extend in all that. It's nothing like that Eylea has got longer duration, you can do with these. So 8 weekly injections, now she is maintaining 6-12 vision. I'm not injecting in the right eye, that's vision is gone. So this I am keeping it. So that's another patient, 76-year-old female with a RAP lesion, retinal pneumosis progression. Multiple injections were even previously given, and patient maintained 2 monthly injections. So here you can see that the large CNV, so she's maintaining 6-9 vision. But the reason you have to keep injecting, so it's not if you stop the injection or you increase the duration, very likely that, and her other eye vision is only counter finger, unfortunately. So she is on 12 weeks lead Fetisra now. So we're keeping up till 12 weekly and she is maintaining the good vision. So this 76-year-old, that's the doctor patient, he has got large CNV both, and he had basically patchy treatments. So doctors were injecting, everything is fine, then he was stopped over. So what happens if you do patchy treatment, choroidal vessels keep on developing, it keeps on growing, and I'll show later that what happens. So refer to me, I treated with Eylea. Initially we gave monthly injections, and then we moved to stabilized. One eye we are doing 2 monthly, other eye we are doing 3 monthly. And even here you can see very large CNV, and no intraretinal edema, you can see subretinal fluid, and maintaining good vision in both eyes. So coming quickly to the tachyphylaxis, I think tachyphylaxis or non-responder we talk about if persistent subretinal fluid, if the fluid is not going away, continuous loss of vision, or lesion is still growing. So there is a growth of the lesion, it's still happening. And why does it happen? VEGF resistance can happen there. There can be other mediators so that can be acting, so you're blocking certain, but there are some other which may be acting. Or even your vessels, pericyte formation can happen. They get matured, so they become like arteries. So that again can lead to non-responsiveness. And again, important thing to keep the variants in the mind. So maybe you're treating the condition, but you're ignoring these, so that maybe the IPCV may not respond much. You will require PDT in those cases. Even that I talked about, neovascularization, arteritis. RAP lesions, again, they require multiple treatments. They need to have a treatment for the long lesion, long duration. Steroids so far don't have any role, so there is no data that tells that steroids are helpful. PDT, we know that in polychoroidal choroidal vasculopathy, yes, it has got role, but not in the wet AMD otherwise. So previously PDT was used in early 2000 when we didn't have anti-VEGF, but unfortunately the vision wasn't improving and they were still in decline. So that's a PCV, you can see pre-PDT, and that later, so polyps are resolved, the fluid is gone, exudation is completely gone here. So combination treatment, already as mentioned, PDT and anti-VEGF, that trials have shown, and it is effective that IPCV, you can use it. So surgery, I think some macular hemorrhages, yes, you can inject subretinal TPA, but again, anti-VEGF is the main stay of the treatment in those cases. Macular translocation was buzzword many years ago, but vision didn't improve much. Too complicated surgery. Choroidal RP patch, again, very subtle amount of lumen, not much improvement, so that again is not as popular. So mainly the treatment, so that just show the video of subretinal TPA. So it's, I think it's around maybe 11-year-old video. It was in UK when I injected 2012 or something. So needle is further finer. It's it was a 38 gauge needle. Now it's a 41 gauge needle. So you have so you inject beneath, and you just inject the TPS. Avastin or anti-VEGF, you can inject intravitreal. Some people argue that you can inject there as well and finish up the case. So, benefits of Treat-to-Extend, it has got similar efficacy and safety outcome requiring fewer injections. So, monthly injections, say if you compare it, it's like a similar effect you can get. And benefit patient burden is reduced and you have a more efficient service. Has shown that up to 60% of the patients can go up to 12 weeks. So after 12 weeks, 60% of the patients you are treating with aflibercept, they will remain stable. And around 46% up to 16 weeks, you can go up to. So that's why I'm saying all anti-VEGFs you can manipulate and you can extend the time. So I'll finish up my talk with early detection and timely treatment is the most important thing. Anti-VEGF is the treatment of choice. There is no other treatment, so you have to stick to that. You can go according to your circumstances, whichever you are using, that's fine. And patient requires treatment for a longer duration. If you're stopping the treatment, always keep in mind to keep those patients on the follow-up. Just keep following, like 4 to 6 weeks or 8 weeks, you can keep the follow-up time. Thank you very much.
And see, low vision department has a very important role
Absolutely.
for different VR diseases. I have a lot of interest, so
Yeah.
even if a patient goes blind, I ask my optometrist to help them to do morbidity training and to change their lifestyle. So
That's very important.
And please join us for overall meeting. That's coming up.
If you're not able to sign the check, that's important.
Yeah.
Actually, check the sign kar sakte hain. So there, it's very important for vision aids.
In this short of time, you take few questions. Assalamualaikum sir, very good.
Walaikum
Thank you. As all the stakeholders of PVR are here, I'm Majid from Peshawar, Sir, just a comment, suggestion that we are seeing a shift from Avastin to ranibizumab or aflibercept recently, and a lot of patients are receiving ranibizumab, but in near future the SP changes and the Avastin is again widely available and we are injecting the patients back to Avastin, we are shifting them. So there should be a multi-center trial to check the efficacy of shifting the patients from a higher end or FDA approved ranibizumab or aflibercept to Avastin after 1 or 2 injections. So this is just a suggestion or comment. Thank you so much.
You're still injecting growth. So,
Why you?
Is available and I mean, what is
Just
important?
the one patient, Golicizumab I'm using because other are not giving a response in that case.
Okay.
So that's the reason for. Otherwise,
Shift it at the okay.
yeah, that's the reason because it's just a one patient.
And sometimes just shifting the drug, अब एक drug की response, no response, you changed, again no response, you came to the first drug, there was again no response.
Absolutely, that happens.
Very
because,
funny.
Yeah, it's sometimes you give a gap, response comes. So sometimes you're using a Avastin, you move to Eylea, then patients affordability issue, you move back to a Avastin or something that works. So you need to give some break, and then somehow the response comes
I
out.
would like to give a comment on my personal experience. I'm not injecting Avastin since 2000. Why? Because I found that the efficacy of Avastin was going down. Response ही नहीं आता था. तो फिर पता चला कि it was the problem with the dispensing. वो जो law में आ गए थे, वो जो dispense कर रहे थे, that was not up to the mark. उसकी cold chain को नहीं maintain करते थे. So these are things we have to see personally.
I think what we do in Shifa is we have fixed the date. Even previously, it's like that. So same day and same day we use and just discard.
That's the only advice.
That's the only. So it works.
Still, poor patients are being affected because of the unavailability of Avastin.
Thank you. Thank you, sir.
The next talk is by Dr. Imran Ahmed about anti-VEGF role in ROP.
इसका लास्ट पे करके ये बर्जन निकालेंगे हम
सर आप फिर निकलने वाले हैं इसलिए
अब तो लास्ट में निकले
Bismillahirrahmanirrahim. Assalamu alaikum. I will talk about the role of anti-VEGF and patients with retinopathy of prematurity. Before going for the treatment of retinopathy of prematurity, because so many trainees are here, and actually retinopathy of prematurity is not examined by the trainees, so I have to go for the pathophysiology and also classification and what are the indications for treatment and patients with retinopathy of prematurity. Premature birth is actually anyone born before 37 completed weeks of gestation is a preterm baby, and if the duration of gestation it is less than 32 weeks, it means that there are high chances of vascular disease, retinal vascular disease, that is retinopathy of prematurity. And developer actually birth weight less than 1500 grams are gestation age of less than 32 weeks. All these are screens for the retinopathy of prematurity.
Just wait a minute to correct. We follow PROPERA guidelines in Pakistan, and here any child born less than 35 weeks and weight less than 2 kg. This is not international. This is PROPERA.
That was actually made by the OSP task force on retinopathy of prematurity. That is 35 weeks.
And weight to
Less than 2. And if anyone, if the weight is less than 2 kg, still we have to go for the retinopathy of prematurity screening. So basically, what happens that initially the vasculation of the retina, it starts from 16 weeks of gestation, and then on the nasal periphery it reaches there and completed by 32 weeks of gestation. Whereas the temporal periphery, that is completed at 40 weeks of gestation. So again, it depends on the duration of prematurity, that when the baby was delivered. Actually, let's suppose if a baby is delivered at 30 weeks, so there will be some nasal retina will be spared, that will be avascular, and also the temporal one as well. So normally what happens that the retinal hypoxia is there because of the immature growth of the retinal tissue, and it releases the VEGF, and that VEGF is responsible actually for developing and the vascularization of the peripheral retina. Blood vessels develop and occur in response to the normal hypoxia and normal release of VEGF. So what happens in the patients with retinopathy prematurity, actually at birth and the intrauterine life, the partial pressure of arterial oxygen, that is less than that after birth. One is that thing. Second thing, if these babies are given increased amount of oxygenation or liberal use of oxygenation, it leads to the development of retinopathy prematurity. If there is increased oxygenation, actually there is increased risk of ROP, and if the use of oxygenation that is reduced, there is decreased chances of ROP, but at the cost of the life of the babies. And so many, it was actually way back from 1960s, 50s, 70s, actually these studies were done. And with the use of oxygen, the parenteral oxygen that is given, if it is reduced, there is increased chance of mortality. So we have to give controlled oxygen to these babies. Normally there is retinal hypoxia, which will lead to the normal release of vascular endothelial growth factor, and vascular endothelial growth factor then leads to the normal development of the vascular tissue. But if there is hyperoxia after birth of the baby, or if the baby is given injudicial use of hyperoxia or oxygen is given, it leads to the down regulation of vascular endothelial growth factors. Then along with the down regulation of VEGF, because of the hyperoxia, there is vasoconstriction and vasoobliteration, and that results in halting of the blood vessel growth. And release, after when the baby is taken out of the oxygen, there is a sudden surge of VEGF release, and we know that VEGF is responsible for the angiogenesis. It causes angiogenesis, resulting in the retinopathy of prematurity. Nowadays, the classification we are using, actually the international classification of retinopathy of prematurity, and the third edition that was decided in 2022 and then published in decided in 2021 and published in 2022. And basically depends on the location, severity, extent of the disease, and whether plus or P plus is present or not. So for the trainees, actually the location is first is the zone 1, and any disease in this region that should be closely monitored, and it is associated with so many complications. So the zone 1 is actually the distance between the optic disc and the macula. Twice to that, if you draw a circle, that is the zone 1. Then the zone 2, if we start from the nasal periphery, draw a circle, that is the zone 2, and the temporal crescent, that is actually the zone 3. By the international classification of retinopathy of prematurity, the third edition, they have given another zone, that is posterior zone 2. 2 disc diameter from the zone 1, that is the zone 2. And actually its indication for the treatment. if there is associated plus disease. So coming to the stages of ROP, stage 1, 2, 3 and 4. Actually, in stage 1 there will be only a demarcation line will be present, avascular retina and the vascular retina. Find demarcation line in the zone 1, and zone 2 actually it then gets wet and starts elevation, that is the zone 2, stage 2 sorry. Then stage 3, if there is fibrovascular proliferation, extraretinal going into the vitreous are going over the ridge, that is zone 3. Then stage 4A and B, partial retinal detachment not involving the macular region, zone 4, stage 4A, and 4B if it's involving the macular region. If there is total retinal detachment, that is zone 5, stage 5. Then the plus disease actually, it shows the severity of the disease. If there is vascular tortuosity mainly involving the posterior pole, there will be poor dilation of the patient, vascular engorgement of the iris, hazy view, all these comes in the plus disease. And actually a pre-plus terminology was also there, and it is if any disease less severe and if it is involving tortuosities in the periphery, that is a 3+. Aggressive ROP actually, previously aggressive posterior ROP, that was replaced in this classification by aggressive ROP. And you can see over here, there is totally peripheral avascular retina, there vascular tortuosity involving the zone 1. There are hemorrhages, peripheral avascular retina. Actually, these patients or these babies should be treated within 24 hours. And it's an indication for the anti-VEGF. So coming to the treatment for the retinopathy of prematurity, actually VEGF is normally required for the babies, and it's for the development of the kidneys, lungs, livers, brains, and skeletal as well. Neurons, neuronal tissues, and for the blood-brain barriers, kidney, lungs, and skeletal development, VEGF, normal amount of VEGF is needed. So we are having the option for the cryotherapy, and that was previously, that's in the late 80s, that is the cryo-ROP trial that was conducted, and it showed that cryotherapy is effective treatment for the ROP at that time. Then came the laser, and the early 2000s, that laser is very much effective in comparison with the cryo because it's more safe procedure, good target can be met, and exactly the same location can be lasered. Then started the era of anti-VEGF. I will discuss it in detail, and the surgery and sometimes combined procedures is also needed, that you have to give anti-VEGF along with the lasers.
1 minute, sorry to interrupt, Imran.
Yes.
This is very important for trainees, that any premature baby that is born is not to be for the screening. We have to give a time to come afterwards.
Exactly, for the ROP
For
to
example,
develop.
if the child is born at 26 weeks, 28, 30, 32, so the optometrist or someone in the nursery would ask the parents to bring the child after 2 weeks, 4 weeks, 6 weeks.
Usually 4 to 6 weeks,
Yes,
exactly.
or if the child is in the NICU, best is to examine this, not on that day, but after the postnatal birth.
Exactly. So actually the lasers were having so many problems. It's a time-consuming procedure, usually take 30 to 40 minutes, even up to 1 hour. Decreased night vision, because we know it's a complication with all lasers. There is also peripheral vision. There is high induction. Even some patients are having high myopia with the lasers. Decreased peripheral vision again because we have to destroy the peripheral retina. It's a difficult procedure, and special training is needed everybody because we have to do it with the indirect laser, and may need general anesthesia as well. The advantage of the anti-VEGF is there is rapid regression of the retinopathy of prematurity with anti-VEGF. Retinal revascularization occurs, and the refractive change is very much less because various trial has been done on this in comparison with the lasers. And it's a faster procedure because we have to inject anti-VEGF. It takes about 2 to 3 minutes to inject anti-VEGF rather than laser that needs about 30 to 40 minutes. And less pain. Half-life, first the bevacizumab, the half-life and the vitreous is 5.5 days. Serum half-life is 21 days. Serum VEGF is reduced till 18 weeks. Means if you are giving Avastin to these patients, to babies, the serum normal level of VEGF is down regulated, and it remains down for up to 8 weeks. As I already mentioned that these VEGF is normally needed for organogenesis. The beta-ROP trial was actually conducted, and it was indicated for the zone 1 and zone 2, posterior zone 2 disease. And half of the adult doses given, usually 0.6 to 5.
And also mention the distance from limbus.
That is 1 millimeter. We are giving it in 1 millimeter from the limbus.
It's not like adults.
Exactly, not like adults. And then the laser, it was compared with the laser, and that showed that more than 80% of the babies, the ROP was regressed. Then PEDIC 1 and 2, actually it was the pediatric eye disease investigative studies, and they actually basically various doses of anti-VEGF were given. 0.3, even very low doses, even 16th of the adult dose was given. And all the doses which were given to the babies, actually there was regression of ROP. Then actually the main anti-VEGF that is indicated for the retinopathic prematurity, that is ranibizumab, because serum level is up to 30 days and half-life in the vitreous is 5.4 days, and it is having no systemic effect or no effect on the systemic VEGF. So we can give it will not suppress the systemic VEGF which is normally needed for the development of babies. And for that, actually the first was a pilot study that was clear ROP, in which the half dose of the ranibizumab was used, 0.2 milligram, and it showed that 82% of the babies, actually the ROP was regressed. Then it was the Rainbow trial was actually as an extension of the CARE ROP, and Rainbow trial, actually it was a multi-center trial involving about 26 to 27 centers. And again, they checked for up to 2 years the effect of ranibizumab on the retinopathic prematurity. And it showed that at 80%, and this trial that showed that the ROP regressed. Then another trial that is still going on, I think it will be finished in 2023, and it was the effect, the long-term effect of the ranibizumab, that is Rainbow extension trial, whether it is affecting having systemic effect on the refractive error of the babies. Another anti-VEGF, that is aflibercept, serum half-life is 5 to 6 days, and actually the ranibizumab after Rainbow trial that was approved in the European Union, not in the USA by FDA. For the aflibercept Firefly study and Butterfly study, actually these were conducted again for the ROPs, and after these studies, it showed that in the Firefly there was at 6% regression of ROP babies, and in Butterfly it was 80%. And after the Fireflies and Butterfly study, actually aflibercept was the only anti-VEGF which was approved by FDA for the use in retinopathic prematurity. Actually, we need long-term systemic profile as well, because long-term, actually, we have to check these babies whether there are developmental or organogenesis problems are there or not. And VEGF is essential for angiogenesis regulation, normal angiogenesis, because again, it depends on the amount of the avascular retina. The more the amount of avascular retina, more VEGF will be released and more will be the consequences of that. Again, if there is small amount of peripheral avascular retina, even with the passage of time, and that's the reason that in about 85% of the retinopathic prematurity, it doesn't need any treatment. Systemic absorption of the drug, again, it's a problem with the anti-VEGF. Which drug we need, which is immediately effective, because we need these drugs for the aggressive diseases involving the posterior pole, that is the zone 1 or posterior zone 2. So immediately effect is needed, and mostly the effect is visible after anti-VEGF, and it's having dramatic effect in comparison if you compare the anti-VEGF with the diabetic macular edema or vascular occlusion. And within 2 to 3 days, the effect is there. Does not have systemic complication, which is the ranibizumab, which is not having systemic complication in comparison with the bevacizumab, and normal vascular growth is there. Whether we have to repeat anti-VEGF or not, usually it's not needed, but sometimes it's needed in rare conditions, and usually one anti-VEGF injection is enough. If there is severe reactivation of the disease, again going to the plus stage, we have to re-inject, and then again we have to look for the peripheral avascular retina, and such babies usually need peripheral lasers. Laser done, and still there is activation, again we can go for the anti-VEGF, and we have to look for the avascular retina. If there is any area that has not been lasered, we have to go for the indirect laser. And poor vascular growth. Actually, we have started this a few years back, and Madam actually started it. He was the pioneer of retinopathic prematurity. We started for the first time at NKTH in KPK, and so far it's encouraging for us that so far
6 hospitals. 6 hospitals of KPK are doing ROP screening now.
JJ Madam. Actually, so far no baby has went into the complicated stage which is under our treatment. We have injected bevacizumab and these babies, ranibizumab, and even for the indirect laser as well. Thank you very much.
One very important thing is the role of neonatologists in ROP. In Sawabi Hospital and Reman Medical Institute, they mention on the discharge slip as an instruction for premature babies that are filling the criteria to go for ROP screening. So this is very, very important. Even they go for hearing and ROP screening. And second is follow-up of these babies, because these are at risk of developing myopia afterwards?
So it is very much important because so many babies we have got in the advanced stage, that is in the stage 5, when there is even bilateral total retinal detachments, and it's very difficult to do surgery in these patients and these babies.
I think nowadays the more difficult problem is to keep those pediatricians to refer the
Yes.
Exactly.
ये सबसे बड़ा मसला है।
And one more thing is,
देखते नहीं, वो कहते हैं कब कहते हैं कि हमें कहाँ है।
Exactly, sir. It's the same like in diabetic patients that even the endocrinologist is not referring to diabetic patients for endocrinology.
इन दिखाएगा कि इसका अपना फंडस की रिपोर्ट लेके।
नहीं, डॉक्टर साहब एक और बात, आप VR सर्जन हैं, तो ये रेटिनल कैमरा का कितना रोल है इसमें? बहुत ज्यादा,
It's the most important thing.
बहुत ज्यादा अच्छे कि indirect?
Most important.
रेड कैमरा? अच्छा, तो सिर्फ 7 करोड़ कह रहे हैं। सर अपने कुत्ता भी बेचते तो नहीं आता।
जो ये मैं बात ध्यान से कहना चाहता हूँ आपने पहले कहा, लेकिन I think has been a great, let me tell you, use of indirect ophthalmoscope is very important for anybody who is trying to do it. Let me give you my example. मेरा इंग्लैंड में मेरा पहला दिल था तो उन्होंने मुझे ऐसे जो भेज दिया कि जाके पहले जाके जाओ बच्चों में जाके देखो. It is the most difficult to examine the child, बच्चा baby of this. I think so. It has to be learned and indirect is part and parcel of it, but the most commonly used internationally nowadays is red cam.
सर मैं हम तो inferiority complex का शिकार हो गए।
नहीं,
नहीं, सर पाकिस्तान के इतने हॉस्पिटल्स में और KPK में एक भी नहीं है रेड।
ये KPK में problem है.
Red cam you can buy cheaper one. It's not about
अच्छा,
Chinese.
के नाम से आते हैं
कौन सा?
Chinese जो है that costs about 70 lakh.
अच्छा,
And
कहाँ है ये?
Indian costs, you go to the any international meeting
अच्छा।
and get there from there. And Indian you can buy for 45 lakh. We bought it for 25 lakh 5 years ago.
किस हॉस्पिटल में?
So
ये आपस वाली मशहूरी बात नहीं करेंगे.
she was.
Sorry.
But sir, I think we should, it's a great job you're doing in KPK. जहाँ कहीं नहीं था 6 hospitals and I think it's, okay, I'm just going to talk about the base, most of the things which I'm going to discuss. In fact, I'm not going to discuss because those have been discussed by Dr. Tariq Marbat and Dr. Amir Amal. The things which I would like to tell, I'll only present those slides. So number one, the different names, sex, like every person. Then they are MAPs. Those are monoclonal antibodies, while SEPs are the fusion antibodies. So I don't know why they compare MAPs with the SEPs. But clinically, because these studies, the protocols, and mind you, protocols are not to be followed. These are the real world data you should follow. These are only the guidelines. जो कंपनी वाले बताते हैं ये प्रोटोकॉल है, ये प्रोटोकॉल है, हमें तो नाम भी याद नहीं होते. And sometimes we ask the students in the exam, ये ज्यादती, ठीक है? And then we have like math like a Western and Peshawar. Then there are terminologies on which the research work is done. इसको ऊपर वाला?
Center, ऊपर वाला.
Yeah. These are two parts of the antibodies. This is the crystallizable, and this is the FC component, and this is the real antigen which combines with the anti-VEGF. Sorry, the VEGF. More research is being done on this component. Why? Because it attaches to the receptor, and that is also the cause of inflammation. So the research is on this FC component. Now to understand the pathophysiology is there are multiple things which are producing retinopathy, either in vein occlusion, diabetes or wet AMD. Angiopoietin, erythropoietin, आप इनके सब नाम देखें. There are more than these which we do not know still. And the drugs which are available are against VEGF-A only, and isomer 165 and 121. We are not having any against fibrovascular growth factor or insulin-like growth factors. इनके against है ही नहीं. And secondly, when the drug comes, it tells you the नई वाली आई है, that is the angiopoietin 2 के against, while SET is against the VEGF and Number 2 is the placental growth factor. इन दोनों को कंपेयर करना आई थिंक ज्यादती. So the only thing is you should see the real world data and take the guidelines from the protocol. ये बनाते कैसे is that it's from the mouse, लेकिन जो हम यूज करें it's not from the mouse, it's from the humans. They get antibodies and they reconstruct to which is called the complete humanized antibodies. This is with every person. एक नाम आता है dimer. This thing. So every person has a trap. That is like Mother साहब ने कहा था कि ये trap है. It traps. It's not gets only attached to it, but trap कर लेता है. And this one, ये receptor के साथ लगेगा. So I'm not going to talk about bevacizumab and these are the new drugs. This one is the latest. अभी अवान ने हमें बताया ही. These are drugs, they come and go. To study one drug, they spend $7 to $10 billion. एक molecule निकालने पे. Phase 1, 2, 3 trials. Now, there's a competition between different companies. The main aim is to decrease the financial, the workload on ophthalmologists and on the community by increasing the extent, the injection which can be given after 18 to 16 weeks and loading dose of 3 injections, 4 or 6. I have a question. From where do we get कि हमने loading dose कितनी लगानी? कौन बताता है? Trials. तो पहले 3 इंजेक्शन में तो पहले 3 इंजेक्शन या 6. Facimab पे है you have to give 6 injections in diabetic macular edema. Loading dose 6 और 4 देंगे हम उस पे ARMD पे. Vein occlusion का इसमें जिक्र नहीं. So should we follow that regime or not? Personal experience लोगों का. Should we give the loading dose or the loading dose has no role?
The AMD भी मेरा ख्याल में loading dose work, but for diabetic DME or less aggressive DME है, sometimes one injection will help.
Yes, I agree with you.
और उसके बाद आप उसको laser you can do focal laser or like that. But
Yes,
it's not
you can.
necessarily to give loading dose. It's a customized treatment.
Yeah, of course.
आपने अपनी customized treatment करनी है और मतलब you should not go follow these. I think
If
that's
you
fine.
follow the real world data, वो यही कह रहे हैं. Many ophthalmologists अगर उनके इंटरव्यू करें ना, उन्होंने कहा कि मैं regime को अपना personalize किया हुआ है. I think we should do that.
Exactly.
आप उसकी diabetes control करें, एक टीका लगाएं, देखें, next time देखें उसका क्या बना है. You might not need second injection. लेकिन पहले 3 इंजेक्शन जो है कि लाजमी लगाने हैं. इसमें कोई कानूनी कार्रवाई आपके अगेंस्ट नहीं होगी. हाँ, अगर आप ड्रेग अप्रूव नहीं लगाते तो then you can have a problem. So the answer is the question is should we follow that regime or not? आप करेंगे खान?
सर इशू सिर्फ ये है कि जो ट्रायल्स हैं they have concluded कि हमने more than 60% में जिसमें 3 इंजेक्शन दिए उनमें रिग्रेशन फुल देखी, जिनमें 2 दे के देखे ये शैम में थे या कंट्रोल में थे उनमें नहीं हुई. ठीक है ना. वो ज्यादा ट्रायल्स आप सारे देख रहे हैं वो AMD में है, जैसे नवीन ने कहा.
AMD में diabetic.
DME में मसला ये है कि DME में इतना अच्छा अगर पेशेंट की आप मैं जो 3 इंजेक्शन देता हूँ ना सर, जिसको लोडिंग डोज DME में, वो सिर्फ उसको देता हूँ जिसकी HbA1c 9 या 10 होती है, क्योंकि मुझे पता है कि 3 महीने में मुझे HbA1c चाहिए 7 के साथ. वो 6.8 है, 6.9 है, ये 7 टच हो रहा है. मेरे पास जिस दिन 7 HbA1c आ गई, मैं उस दिन ये जो आपकी लोडिंग डोज है इसको भूल जाता हूँ. फिर मैं PRN पे या ट्रीट एंड एक्सटेंड पे आ जाता हूँ, इवन DME में.
So the thing is, counseling of the patient is very, very important in diabetic patient, not a age-related macular degeneration में, तो entirely different scenario है. In diabetic patient, at least spend 20 minutes to half an hour. उसको पहले बताने में जब आप लाएंगे HbA1c less than 6, ये सारे के सारे फैक्टर्स खत्म हो जाएंगे. इंजेक्शन तो दो फैक्टर को खत्म कर रहे हैं, ये सभी फैक्टर्स खत्म हो जाएंगे if the diabetes is controlled below 6. Then it can take some time, it can take 6 months. उस दौरान you can protect the patient with injections.
इसमें सर अगर HbA1c initial on presentation is very high, it's between 12-13, so वो endocrinologist suggest कि इसको बहुत rapidly आपने down नहीं करना.
हाँ बिल्कुल बिल्कुल take
gradually, yes, इसको sometimes के adverse effect.
Because the body is used to that.
Yes.
तो एकदम से blood pressure उसको नहीं कम करते, it takes some time. तो उस time में you can inject and see what's the response. The vision क्या है? So this slide was to compare. अब ये देखें 6 months का loading dose है DME और इंजेक्शन कितने का आएगा कोई पता नहीं, और 4 महीने ARMD. So I think this should be customized by an individual person.
मोस्टली ट्रायल्स में वो 5 लोडिंग देते हैं. मोस्टली जो ट्रायल्स होते हैं ना वो यही होता है कि उसमें क्लिनिकल ट्रायल्स.
जब वेस्टर्न स्टार्ट आया था लोग ऑस्ट्रेलियन थे वो कहता था मैं तो 6 महीने से पहले पेशेंट को देखता ही नहीं, हर महीने मैं उसको एंटी-VEGF लगाता हूँ फॉर द नेक्स्ट 6 months. और एक जो चीज़ तारिक महमूद ने बताई थी कि दी विवरसिलुमैब वाज अप्रूव्ड इन 2015. DME के लिए पहले अप्रूवल थी. 2015 इट वाज अप्रूव्ड फॉर ऑल टाइप ऑफ डायबिटिक रेटिनोपैथी, चाहे वो पॉलीफेटिव है, स्फेयर है. DME पहले हो गई 2006 से 7.
तारिक साहब 2010 में तो उसकी बोर्ड स्टडी आई थी,
तो उसमें सब हाँ कंपैरिजन में तो उस वक्त ये DME के लिए हो गई थी. इन 2015 में वो ऑल टाइप ऑफ डायबिटिक के लिए अप्रूव हुई है. So when you select the anti-VEGF, we have to see these things. You keep on injecting anti-VEGF in ARMD, they end up in geographical atrophy because of the side effects they have on the retinal tissues, other than the blood vessels. Because normal VEGF is needed for what? For RP. अगर RP का भी VEGF कम हो जाएगा उसके लिए, because they are in a growing fashion, photoreceptors का भी. So that is the local damage to the retinal tissue. We should see that. जितने हम ज़्यादा लगाएंगे, end result will be a scar. अभी तक जितनी ट्रीटमेंट हम देखी हैं, we have only been delaying the scar in most of the patients. Myopic CME is different thing. बाकी CMEs because of any of the cause is different thing. But age-related, I think we are just delaying the scar by these and making the life of the patient better for 4, 5 or 6 years. This was again the comparison between the systemic absorption, and the systemic absorption was maximum in bevacizumab. So number of injections we can personalize and decrease in every patient. वो खाली हम पे नहीं बल्कि पेशेंट का भी बर्डन कम होगा और सोसाइटी पे भी. The patients cannot afford. और जब से ये वेस्टर्न बंद हुआ है, you can see the condition of the patients. Nobody can do anything. अब जो SOPs आए हैं कि जी पूरा वाइल है, इंजेक्शन खुद बनाएं. Even the tertiary care centers are reluctant in doing that. कि कुछ हो गया तो आपका थिएटर सील कर देंगे. What to do? I don't know what to do. आप कर रहे हैं यहाँ पे वैसे लगा रहे हैं
फिर शुरू कर दिया जी.
इसी तरीके से.
हम पठान पहले रिस्क लेते हैं.
So thank you. That was all about my talk. Thank you.
Thank you, sir. The next presentation is on the anti-VEGF versus steroids. Bismillahirrahmanirrahim. It's just a change to the what now we have been discussing so far. It is all anti-VEGF till now. But we will be discussing is there any role for steroids still in this era or not? Whatever we are discussing in the trials are patients from the Europe, not from our population, because our population people will be coming with these sort of macular edemas. And when they will present to you with a history of decreased vision for last 1 or 2 months, if you ask them, they will say, अभी 1 महीना से बस विजन ड्रॉप हुई है। हालांकि ये मानने वाली बात नहीं होती कि डीएमई का ये मरीज 1 महीने में ऐसे बना होगा। जब आप हिस्ट्री फिर लेते हैं तो you come to know कि 1-2 साल पहले उसको कुछ एवेस्टिन लग गए थे, बस फिर उसने छोड़ दिया। And now it comes again because there is more drop in the vision. So what are the treatment options in this, like Professor Tariq Khan has said, in the real world scenario, when you are dealing these patients in your setup with such history, so what is the treatment option that first comes to your mind for these patients that he will lose again? If you give him an anti-VEGF, how much anti-VEGF you are going to give again to these patients? Or you come across such dense exudate, a hard exudate patient with chronic edema and atrophy of the macula. So what are you going to go for, steroids or anti-VEGF? Yes. There is no doubt that the anti-VEGF are the best one for the DME, and they're the first time treatment. You cannot deny that. But you have, when you are treating the patient, you have to have some second line treatment option, and these are the steroids. The important thing is you do not forget the steroids while you are managing these patients with anti-VEGF. You always have to keep in mind that you have another best drug for these patients, and these are steroids. There are fancy names of anti-VEGF, and there are more coming on to the scene and all discussions on anti-VEGF, but these steroids have helped a lot the patients when there were no anti-VEGF, and they're still currently helping the patients, like in our situation that we are not having anti-VEGF, so still we are managing diabetic macular edema patients with steroids. Why the steroids are still in the role? Because there are some potential issues with anti-VEGF. If there weren't any issues with anti-VEGF, then steroid would have been totally out of the scene now. But there are some anti-VEGF issues. These issues are to some extent significant, and in some studies it has shown that it has been reported but not significant. But you have to keep in mind these issues. Number one is that it has been reported that anti-VEGF can increase the incidence of geographic atrophy when the patients were treated with multiple repeated injections of anti-VEGF. And the evidence comes from quite the renowned trials, the IVAN and the Harvard trials. The other is the complications and the risk associated with anti-VEGF repeat injection is the increased risk of ocular hypertension documented in a large number of studies. So it's not only the steroids which are notorious for causing glaucoma or ocular hypertension, but anti-VEGF also has been linked to the increased risk of ocular hypertension, and it is more, the risk increases when the frequency of injection increases or there are any other pre-existing risk factors for glaucoma. So you have to follow the anti-VEGF patients who are repeatedly injected with a repeat check of IOP and the glaucoma screening. It increases ischemia and traction as well. So you have to be careful, like anti-VEGF crunch syndrome. So you don't have to inject anti-VEGF in all the cases. You have to look what are the cases you are injecting. If there is epiretinal membrane, you have to cautiously inject in these patients the anti-VEGF. And some studies have reported anti-ischemic optic neuropathy, retinal vascular occlusion, and exacerbation of ocular ischemic syndromes. Another in our treatment scenario is the cost of treatment. Even in the West, just like Sir said, how much loading dose are you going to inject in these patients? You're going to continuously inject, and the patient will lose follow-up. And ultimately, he will come up with a more aggressive disease. The cold chain issues, the compounding pharmacy, transportation issues, that's now a burning topic, and what we are now having a challenge to deal with, how to maintain this. These issues are not there with the steroids. So it's a very cheap, effective, and there are no any transportation or the compounding pharmacies are involved in the injecting any sort of intravitreal steroid or suprachoroidal. And the chain of endophthalmitis reactions that occur with anti-VEGF, this issue is not there with the steroids. You can have isolated reactions with any injection, but the series of outbreaks is seen only with the anti-VEGF. Similarly, the systemic VEGF inhibition by the anti-VEGF drugs is also reported to cause arterial thromboembolic events like MI or CVA, although they are less significant, but still there is a risk factor. So you have to keep in mind the patient presenting with a recent MI or CVA, so you have to inject anti-VEGF with caution in these patients, especially the bevacizumab. Just summarizing the brief history, the mechanism, pathophysiology of macular edema, there is chronic hyperglycemia resulting in the retinal capillary endothelial junction adhesion. The capillary endothelial cells are lost, and as a result, inflammatory mediators are released, the interleukins, TNF, and the VEGF, which causes increased permeability again, and ultimately there is a macular edema. These two mechanisms are very important because the two drugs are acting on different pathways. The anti-VEGF blocks the VEGF, but the steroids block these inflammatory cytokines, and which helps to control the macular edema. What happens in chronic DME is that it has been found in studies that your patient, a chronic DME patient or refractive DME patient, these patients usually have normal low VEGF levels. That's why the anti-VEGF usually are not working. So in these patients, there are high level of inflammatory markers, and that is why the steroids help in these patients. We will be injecting, we have come across patients treated with multiple anti-VEGF, but when you suddenly inject steroids, suprachoroidal or intravitreal, they will suddenly come back to you and say that this injection now works more better, because there are other inflammatory mediators which the steroids block. So the mechanism of action of steroids, as you all know, that it inhibits the prostaglandins and leukotrienes, it downregulates the pro-inflammatory cytokines, it prevents the leukocyte migration. This is very important in the causing the inflammation in the DME. And it improves the barrier function of endothelial cell junctions. And it also causes down regulation of VEGF as well to a little extent. So the three-pronged action is anti-inflammatory, anti-apoptotic, and anti-angiogenic function. There are different options for steroids use. One is the intravitreal route, the suprachoroidal route. Previously, there was a delivery device by name of Ivation, and then the implants. Nowadays, the suprachoroid and the implants are the mainstay of treatment for management of diabetic macular edema. Just a brief history, the intravitreal steroids were the mainstay of treatment before anti-VEGF, and the evidence was also assessed in the DRCR protocols, and the protocol B showed that it was inferior to the focal and grid laser in long-term follow-up because their patients were more having complications with steroids. But protocol I, in this, it was compared with anti-VEGF and laser. Definitely ranibizumab performed much better as compared to the rest of the groups. But, sorry for the font color, the pseudophakic patients, the triamcinolone performed as equally good as ranibizumab. So just to keep the point, if you are having a patient with pseudophakia and if he's a vitrectomized patient, the steroids can work as better as anti-VEGF in those patients. Nowadays, suprachoroidal steroids are a very vision-saving drug in our scenario. The suprachoroidal space is a potential space located between the sclera and choroid, and it does not have any risk of intraocular penetration. The risk associated with intraocular penetration. The animal studies have shown that the drug accumulates more in the retina and the suprachoroidal space, and there is minimal access to the anterior segment. That is why the anterior segment complications are minimally encountered with suprachoroid mode of steroid administration. There are different trials that have been done on the suprachoroid. One is the Dogwood and Goldstein studies demonstrated its efficacy first in the uveitis. After that, leading to another PhD study which shows the improvement in macular thickness. Regarding the DME, the Hull study showed that there was great improvement in the central macular thickness in the groups that were treated with suprachoroid as compared to the combination groups that were treated with aflibercept. In another study, Tybee demonstrated that the combination group had shown better outcome in the central macular thickness as compared to aflibercept. So these studies have shown that if you are having patients with DME and you manage them as compared to even the anti-VEGF, the latest one, so you can still have comparable and better results with suprachoroid. The Tanzanite study was carried out in the vein occlusion patients, and it again showed significant patients showed better improvement with the suprachoroid as compared to combination. So one of the patients treated with multiple anti-VEGF and then treat it with 1 dose of strobilurin and you see a dramatic result. And this result is obvious within a month. The second is the implants. Unfortunately, the implants are not available here. You can order for a patient, but still it's one of the better treatment option because you get a sustained release mode of action in these cases. The Orthodex was approved by, had shown the vision improvement in three line standard vision improvement in 22% of the patients in the MEET study. It is a 0.7 milligram implant and biodegradable implant and efficacy lasts for about 3 to 6 months. This is the image shown, shared by my friend working abroad, and the injection was given on after 2 weeks. This eye showed this type of improvement. It is a dramatic improvement, and he had received multiple ranibizumab injections in this eye. Another is the fluocinolone implant by the name of Illuvian 0.19 milligram, and it is also sustained release and efficacy can last up to years. This again, the common complications with all the implants is the increased incidence of cataract and glaucoma or the ocular hypertension. So you have to take care of these. Ivation was a device used previously, but now it's not in use. So coming to the recommendation for steroid use. Steroids are actually the second line drugs for managing macular edema. And it is used in cases when there is a persistent or refractory DME, or the patient is having any contraindication to the use of anti-VEGF, or like in our scenario, there is no availability nowadays. So you have to keep this in mind and treat the patient. And it's more suitable for pseudophakic patients or those who are near to have their cataract surgery in near future. So the benefits are reduced injection frequency, there's reduced financial burden, can be given in cases where anti-VEGF cannot be given, and there's no cold chain issues, but the drawbacks are cataract and glaucoma. So you do not have to forget steroids while managing patient with DME. Always, it's better to have steroids with you. Thank you. The next talk is by Professor Hussain Ahmad Khakan about the legal implications of anti-VEGF.
The most important.
The most important one.
Good afternoon, ladies and gentlemen. I know you are tired from listening all the day anti-VEGF. I am thankful for Professor Naula Jan, Professor Shad Muhammad, Professor Dawood, Professor Zaid, and Professor Ziaul Islam for invitation at this prestigious meeting. And it is after the long time that PVRS has the symposium. I think way after the 2018 we didn't have. Because of the COVID and due to other reasons. So just a little comment regarding the Imran presentation regarding the steroid. The only thing is that it doesn't decrease the frequency. Steroid should be injected more frequent than the anti-VEGF. So frequency is not their benefit. So steroids are injected more frequently than the anti-VEGF because steroids have a rapid effect in the 8th day and it gets down in the 18th day. So anti-VEGF carries on for 28 days, just that little bit point. So my presentation is more about your questions. It's not about myself or something. I will not go for these anti-VEGF. You have gone all the day. I will just read one line here about worldwide bevacizumab is being commonly used for as off-label drug in the world of ophthalmology. I will try to bring a few explanation regarding these words of off-label, drape, what is Healthcare Commission and what we are going to do in future in Pakistan. So what is off-label? Every ophthalmologist should know this terminology and they should know it. So unapproved use of approved drug. This drug is approved, but it is unapproved. What does it mean? It is approved for something else, but not approved for use of an available drug for a disease or medical condition that has never received FDA approval. Since the FDA doesn't regulate the medical practice, that's why use of off-label drug is common worldwide. FDA एक दवाई की इजाजत देती है यूज करने के लिए. FDA ये नहीं बताती कि आपने इस दवाई को किस बीमारी में यूज कर सकते या नहीं कर सकते. किसी एक बीमारी के लिए भी अगर वो ड्रग यूज हो रही है तो यू कैन यूज इट एनीवे. बट ऑफ लेवल का क्या मतलब है कि उसका किसी और जगह पे आपने फायदा उठाया. जैसे डॉक्टर तारिक ने सुबह पढ़ाया कि 4 में उसने एवेस्टिन को कोलन कैंसर के लिए किया और उसने देखा कि ये एंटी वेजेफ का अच्छा रोल करती है। अब दूसरा सवाल है कि व्हाई वी यूज ऑफ लेबल ड्रग्स। फर्स्ट, ए मेडिकेशन मे नॉट हैव बीन स्टडीड एंड अप्रूव्ड फॉर ए स्पेसिफिक पॉपुलेशन, ठीक है, उसका लिटरेचर रिव्यू होगा, उसका जो कोई ट्रायल्स हुए होंगे, लेकिन वो स्पेसिफिक पॉपुलेशन या स्पेसिफिक डिजीज के लिए नहीं होंगे। सेकंड, ए लाइफ थ्रेटनिंग एंड टर्मिनल मेडिकल कंडीशन may motivate a healthcare professional to give any treatment that is logical, available, whether approved by FDA or not. The very basic example of this thing is life threatening. As we got the COVID wave in 2020 and all the physicians started giving the steroids. Steroids were never tested for the COVID disease. Just to having a life threatening condition, they used it. And steroid that was used for the COVID disease is off-label used. Why nobody stood at that time? So I will keep on going these things as I go on my presentation. The third thing is, if one medication for a class of drug has FDA approval, physicians commonly use other medication in the same class without specific approval for that use for the same indication. If pathological physical features of two conditions are similar, मिसाल के तौर पे आपकी DME और वेन एक्लूजन में मैकुलर एडीमा हो रहा है, पैथोलॉजी सिमिलर है, वैस्कुलर परमेबिलिटी बढ़ी है और एंजियोजेनेसिस हुआ है। अब कोई बंदा ये कहता है कि जी डीएमई के लिए आइलिया अप्रूव्ड है लेकिन वेन एक्लूजन के लिए नहीं है, तो अब मैं आइलिया को अगर वेन एक्लूजन के लिए भी यूज कर रहा हूं तो ये बेसिकली ऑफ लेबल यूज है। क्लियर हुई बात? अब ये जो ऑफ लेबल यूज है ये इसलिए है क्योंकि मैकेनिज्म ऑफ एक्शन ऑफ बोथ डिजीज इज द सिमिलर, और मुझे पता है कि डायबिटिक मैकुलर एडीमा या वेन एक्लूजन के लिए मैकुलर एडीमा का मैकेनिज्म एक ही है, वैस्कुलर परमेबिलिटी बढ़ी, इन्फ्लेमेशन हुई, उससे वैस्कुलर परमेबिलिटी बढ़ी और डीएमई रिलीज हुई, तो ये भी ऑफ लेबल है यूज। ठीक हो गया जी। अच्छा, अब दुनिया में बहुत सारी ड्रग्स हैं जिनका ऑफ लेबल यूज हो रहा है, ये मैंने कोई सैकड़ों के करीब निकाली है, ठीक है। अच्छा, ये देख ले आप कितनी दवाई है। एस्पिरिन का भी ऑफ लेबल यूज हो रहा है। आप सोच सकते हैं जो दुनिया में सबसे ज्यादा कॉमन चीज है वो भी ऑफ लेबल। डर्मेटोलॉजी में है, ये कैंसर ड्रग्स हैं, ये इम्यूनोसप्रेसिव्स हैं, या देखिए एक लाइन है पूरी, आप पढ़ना शुरू करिए, सारी ऑफ लेबल यूज हो रही है। इवन ल्यूकीमिया ड्रग्स भी ऑफ लेबल यूज हो रही है। अच्छा, मसला कहां पे आता है ऑफ लेबल यूज का? ये बात एवरीबॉडी शुड बी वेरी क्लियर। द प्रॉब्लम स्टार्ट्स व्हेन यू हैव ए टू ड्रग्स, they have the same mechanism of action. For example, you have Lucentis and you have a bevacizumab, but Lucentis is FDA approved and Avastin is not FDA approved. Avastin gives you literature review that it has the same effects as the Lucentis has. अब होगा क्या, आप Avastin को यूज कर सकते हो उन्हीं सब बीमारियों के लिए जिसके लिए Lucentis को यूज कर सकते हैं, लेकिन आपको कोई रोक नहीं सकता। Nobody cannot say you कि आप Avastin DME में नहीं लगा, आप लगा सकते हो। इशू कहां पे आता है? But if you get any complication because of that Avastin, when the other drug of similar efficacy and approved by FDA is available in your country, लीगल कैच सिर्फ ये है कि जब आपके मुल्क में एक FDA approved ड्रग हो और उसके होते हुए आप नॉन एफडीए ड्रग जो कि जिसका लिटरेचर रिव्यू ये कहता है कि वो ठीक है लेकिन उससे कॉम्प्लिकेशन हो, सो ओनली द थिंग इज व्हेन यू आर यूजिंग द ऑफ लेबल ड्रग, only you should be careful about the complication that you get and that can be a legal argument on you. और जो हेल्थ केयर कमीशन है वो भी इसी बात पे कहता है, वो कोई नहीं आपको कह रहा कि जी आप बंद कर दो या रोक दो, वो ये सिर्फ ये कह रहे हैं कि जो ऑफ लेबल दुनिया में हर जगह यूज होता है उसकी कॉम्प्लिकेशन के जिम्मेदार आप। आज पाकिस्तान से लुसेंटिस, आइलिया और ब्रोलिसिजुमैब और फेरेसिजुमैब जो आने वाली है ना आने दे, कल आप अवेस्टिन लगाओगे, अवेस्टिन की जो कॉम्प्लिकेशन होगी कोई आप पे लीगल आर्गुमेंट नहीं कर सकता बिकॉज यू डोंट हैव द ऑप्शन। द सिमिलर दैट यू टोल्ड when we didn't have the anti-VEGF before 2004, सारी दुनिया कहती थी कैनाकॉर्ड से बड़ी, तो कैनाकॉर्ड इज ए मिरेकल ड्रग फॉर डायबिटिक मैकुलर एडीमा, और 2009 में गोरे कह रहे थे
इट इज ब्लैक लिस्टेड ड्रग, सुना होगा WOC में, वही गोरे कह रहे थे जी कैनाकॉट ब्लैक लिस्ट करो, ये क्यों लगाते हो कैनाकॉट, वो फ्लागले। तो इसी तरह ये है, ऑफ लेबल ड्रग में इशू तब है जब आपको कॉम्प्लिकेशंस हो, अदरवाइज कोई नहीं रोक सकता आपका, क्योंकि मैंने आपको दिखाई 100 के करीब तो ये मैंने ढूंढ दिया ड्रग जो डिफरेंट, आप एस्पिरिन को ही ले लो। तो ये है सारा।
हाँ, यूरोप में कभी हुआ है ये लीगल एक्शन अगेंस्ट वेस्टर्न लगाने में?
जी सर, हुआ, वो भी इसी कानून पे है। ये सारा मैंने दुनिया का जितना ऑफ लेबल का क्रक्स था ना, ये 3 लाइन नहीं है।
और इंडिया में तो बंद है बिल्कुल।
इंडिया में बंद, क्योंकि इंडिया में पाकिस्तान जैसा सिमिलर एक्ट हुआ था और वहां पे 200 के करीब बंदे इन्फेक्ट हुए थे, और वो एक ही दिन में हुए थे सारे, और उन्होंने 2017 में 16 में बंद कर दिया था। लेकिन उन्होंने बंद इस बेस पे किया था कि उससे पहले डॉक्टर्स कम्युनिटी ने लुसेंटिस की प्राइस 8,000 रुपए पे लेके आए थे इंडियन, तब 8,000 रुपए इंडियन को पाकिस्तानी 13,000 रुपए बनते थे, तो उन्होंने लुसेंटिस को 25,000 से 8,000 में लाए, और देन दे स्टार्ट डिवाइडिंग 2 डोजेस फ्रॉम द लुसेंटिस एट दैट टाइम। तो वो उन्हें पाकिस्तानी रुपयों में मेरे 6,500-7,000 रुपए में तब पड़ता था एक टीका। और दूसरा सर, फिर उन्होंने जो यूज भी किया, अब उनके पास बेसिकली आ गया बायोसिमिलर्स बहुत सारा, बेवासीजुमैब का भी बायोसिमिलर आ गया है, रानीलिजुमैब का भी बायोसिमिलर आ गया, नाउ दे आर मोर यूजिंग द बायोसिमिलर्स। अब पाकिस्तान में क्या इश्यूज है? पाकिस्तान में अवेस्टिन को यूज करने के लिए ड्रैप का अप्रूव होना जरूरी नहीं है। अवेस्टिन इज अप्रूव्ड फ्रॉम ड्रैप फॉर कोलोनिक कैंसर, आपको हर कैंसर अस्पताल में मिलता है। इसको ऑफ लेबल यूज करने में आपको ड्रैप रोक नहीं सकता, लेकिन फिर वही मसला है कि आपकी कॉम्प्लिकेशन होगी, देन यू आर बाउंड कि आप उसको लीगली जस्टिफाई करो कि वो कॉम्प्लिकेशन आपकी कंपाउंडिंग डिस्पेंसिंग से हुई है या किसी और वजह से हुई है। कॉम्प्लिकेशन में 2-3 चीजें हैं, एक सर्जिकल नेग्लिजेंसी है, ये मिस्टेक है, लेंस टच होना या रेटिनल डिटैचमेंट होना, ये एक अलग चीज है, ये सर्जन की है, ये तो आप किसी भी इंट्राओकुलर प्रोसीजर में आप खुद जवाब दें। लेकिन इन्फेक्शन होती है तो देन इट्स लीगल के आप उसको उस ऑफ लेबल यूज में जब यूज करोगे तो वो होगा। पाकिस्तान में बेसिकली 3 रेगुलेटरी अथॉरिटीज हैं, ड्रैप है, हेल्थ केयर कमीशन है और हेल्थ डिपार्टमेंट ऑफ पंजाब। ठीक हो गया जी। ड्रैप से जो भी ड्रग अप्रूव्ड हुई है वो पाकिस्तान में यूज कर सकते हो, कोई उसका कुछ नहीं कहेगा आपको। हेल्थ केयर कमीशन सिर्फ 3 बातें करता है, क्योंकि आई वाज द पार्ट ऑफ दैट टीम जो वैक्सीन के लिए एसओपीज बना रही थी। फिर मैं हेल्थ केयर कमीशन में भी उस टीम का पार्ट था जिसने ये सारे एसओपीज बनाए। अल्टीमेटली आई टू विथड्रॉ माई सेल्फ, क्योंकि वो सब कुछ करने के लिए जा रहे थे जो मेरा ख्याल प्रैक्टिकल नहीं है, जो अभी आ चुका है, इट्स नॉट वेरी मच प्रैक्टिकल। मैंने कहा सर ये चीजें नहीं मुमकिन ना, अगर आप मक्खी पे सिर्फ अप्रूव करते हैं तो इस तरह अप्रूव तो ना करो कि मतलब ये ना करने वाली बात हो। आप तो अप्रूव इस तरह दे रहे हो कि ना ही करोगे, मैं इस तरह का अप्रूवल ही ना करोगे। तो देन आई डिडंट वेंट टू देयर मीटिंग। अब इशू सर उसमें क्या है, वो ये कहते हैं, हेल्थ केयर कमीशन का इशू ये है कि आपका ना कंसेंट फॉर्म पे लिखा हो कि ये ऑफ लेबल ड्रग है, और इसमें डॉक्टर की तरफ से ये कॉम्प्लिकेशन हो सकती है, बाकी कॉम्प्लिकेशन डॉक्टर्स की नहीं है। ठीक हो गया जी। दूसरा, आपका प्रोसीजर फॉर्म, कभी भी किसी ने प्रोसीजर फॉर्म नहीं लिखा अवेस्टिन का। एक प्रोसीजर फॉर्म बना ले, प्रिंटेड बना ले, मतलब हर दफा एक ही काम करते हैं ना, स्पेकुलम डाला, अल्केन का ड्रॉप्स डाला, मैयर किया, इंजेक्शन किया, पैड लगाया, दवाई दी और नीचे साइन कर दिया। एक प्रोसीजर फॉर्म। जिन लोगों के साथ बड़ा मसला हुआ है, अवेस्टिन लगे, कॉम्प्लिकेशन, उन्होंने प्रोसीजर फॉर्म ही नहीं निकलाना सर किसी का, कि किया कब है, किस डेट को किया है, कितने बजे किया है। चलो टाइम भी आप बना मारो अपना, क्लिनिक का कोई एक टाइम ऊपर फिक्स लिख दो, या वो अपने ओटी को। तो ये 2 फॉर्म हर अवेस्टिन लगाने से पहले, मीन इंजेक्शन लगाने से, किसी से भी लगाने से, लेकिन इसके लिए ज्यादा कि अगर कॉम्प्लिकेशन होगी तो देन यू विल बी इन डेंजर। अब जो केसेस हेल्थ केयर कमीशन में है वो सिर्फ इस वजह से है कि रिकॉर्ड नहीं, या दूसरी वजह हेल्थ केयर कमीशन ने, अगर 2 चीजें और आपने करेक्ट करनी है सबने, कोई ऑटोक्लेव, कोई हॉट एयर ओवर आपके ओटी की अंदर नहीं होगा, ओटी के रूम के अंदर। अगर आपका ये होगा, आपका हेल्थ केयर कमीशन आपके इंजेक्शन से होने वाली एंडोथर्माइटिस इन्फेक्शन को उसका जुमा बना के वो आप पे ठप्पा लगा देगा। हॉट एयर ओवर नहीं होना चाहिए। स्क्रब एरिया का दरवाजा आपके ओटी के थ्रू नहीं जाना चाहिए, स्क्रब एरिया का दरवाजा आपका अलहदा चेंजिंग रूम से जाना चाहिए। ये आप 2 चीजें कर लो, कुछ भी नहीं होगा। और हर जो अल्केन की शीशी है या थिएटर में जो शीशी है, उसके ऊपर मार्कर से आपने एक्सपायरी डेट लिखनी है, अपनी ओपन खोलने की भी डेट। देखिए, एक कोलीग के साथ ये इशू हुआ कि उसका सारा थिएटर नीट एंड टाइडी था, उसके थिएटर में अल्केन की शीशी पड़ी थी, उन्होंने कहा जी ये कब खोली है जी, कोई पता नहीं। डेट और उस पर उसका थिएटर सील कर दिया गया, ये अवेस्टिन के चक्करों में। तो आप जो भी थिएटर में चीज है ना उसके खोलने की, किस दिन बॉटल ओपन किया ऐसी डेट मार्कर के साथ आपका OTA डाल दिया करें। तो ये 3-4 चीजें हैं जो बेसिकली आपको करने की जरूरत है। इसमें जो अवेस्टिन वाला इशू है, अब ड्रैप अभी बने ही हमारे पास 10-11 साल हुए हैं और हेल्थ केयर कमीशन को तो बने 9 साल हुए हैं, तो उनके पास भी इतना अच्छा डाटा नहीं है जो वो कुछ कर सके। और ये बेसिकली ऑफ लेबल ड्रग्स हैं जो पाकिस्तान में यूज हो रही हैं ज़्यादातर। और अब पाकिस्तान में जो ये अवेस्टिन वाला है, अब उन्होंने जो SOPs दिए हैं, अगर आप देखें तो SOPs उन्हीं के लिए सूटेबल है जो पब्लिक सेक्टर में काम करते हैं। प्राइवेट सेक्टर में आपका लैमिनर फ्लो होना ज़रूरी है, आपका वैक्यूम ग्लव होना ज़रूरी है, और फिर डिस्पेंसिंग आप उसी वाल से करें, वो चाहे 3 इंजेक्शन बनाने हैं चाहे 70 बनाने हैं। तो वो जिनमें जैसे अल-शिफा में है या बड़े इंस्टीट्यूट जहाँ पे इतना पेशेंट का बल्क होता है वहाँ पे तो ठीक है। लेकिन एक बात फिर भी है, अगर फिर भी SOPs करने के बावजूद भी इन्फेक्शन होती है तो लीगली आप आएगा, क्योंकि ये स्टिल ऑफ लेबल ही यूज हो रही है। ये नहीं होगा कि अब मैंने सारे SOPs पूरे कर लिए जो हेल्थ केयर कमीशन ने दिए हैं या वजीर आला साहब ने जो अप्रूव किए हैं वो कर लूंगा। होगी इन्फेक्शन तो फिर कानून वही है दुनिया में ऑफ लेबल का, क्योंकि ऑफ लेबल का कानून दुनिया में और कोई नहीं बन पाया। हाँ जी,
इन्फेक्शन का रिस्क तो बेसिकली
इनमें भी है,
कोई एंटी-VEGF वो सब में है,
इनमें भी है। अब इसमें क्यों उन्होंने कहा इस उनमें देखे ना। अब मैं एक मीटिंग में था, ये जर्मन डॉग जो मीटिंग है उसमें ऑस्ट्रिया के एक हॉस्पिटल का 16% इन्फेक्शन रेट आया। वो सारे खड़े हो गए, ये क्या बकवास, 100 में से 16 टीके आपके खराब हो रहे। वो क्या करते थे, वो थिएटर के कॉरिडोर में लगाते थे। तो इस तरह के इनमें है 1%, लेस देन 1% रिस्क तो है, लेकिन अमर उसमें आपकी लीगली नहीं आ पाओगे ना, इसमें ऑफ लेबल यूज में नहीं आओगे। उसमें आप जवाबदेह हो, लिटरेचर आपका देगा कि जी आइलिया के बाद 1% एंडोथर्माइटिस होता है, कोई आपको पकड़ेगा नहीं। लेकिन जब आप ये बताओगे कि अवेस्टिन के बाद हुआ है एंडोथर्माइटिस, तो ऑफ लेबल में यू कैन नॉट जस्टिफाई दैट कंपनी।
कंसेंट का क्या फायदा है अगर
कंसेंट
लेवल मेंशन कर रहे हो?
कंसेंट में सिर्फ ऑफ लेवल मेंशन कर रहे हो, आपको उतनी वो नहीं तको दो बाद में करनी पड़ेगी जितनी नहीं करो, क्योंकि वो एक लीगल डॉक्यूमेंट आपका होगा।
Consent is not a legal document.
सर कंसेंट लीगल डॉक्यूमेंट,
वैल्यू किसी चीज
लेकिन पेशेंट कोर्ट में जाने से पहले,
सर मैं आपको बताता हूँ, देखे पेशेंट कोई कोर्ट में नहीं जा सकता जब तक हेल्थ केयर कमीशन उसे इजाजत ना दे। हेल्थ केयर कमीशन का सबसे पहला सवाल होता है, मैं मेंबर ऑफ हेल्थ केयर कमीशन बोर्ड फॉर एनी नेग्लिजेंस, और सर उनका सर जो भी मैं फाइलें डॉक्टर्स की देखता हूँ 2 सवाल होते हैं। डॉक्टर साहब ने ये लिखा है कि ये पुअर प्रोग्नोसिस है कि नहीं है, या गुड प्रोग्नोसिस है। जिस डॉक्टर ने सर पुअर प्रोग्नोसिस लिखा है ना कि सर्जिकल प्रोसीजर कोई भी डिटैचमेंट का या एंडोथर्माइटिस का, सर मैं खुद लिख के आता हूँ कि जी डॉक्टर की कोई नेग्लिजेंस, उसने बताया हुआ है वो क्या करे, कोई केस नहीं बनता। फंसता वहां पे है, ना सर्जिकल नोट्स है, सब ना कंसेंट फॉर्म है और ना पोस्ट ऑफ नोट्स है। जिसके फर्स्ट पोस्ट ऑफ डे के पोस्ट ऑफ नोट्स है, जिसका कंसेंट फॉर्म है डेट वाइज, और जिसका प्रोसीजर नोट सर क्या होता है, वही 3 पोर्ट्स बनाई हुई अंदर के विटनेस काटा था, 4 लाइनें आप प्रिंट करके रख लो, वो है कुछ नहीं। अल्लाह माफ करे, वो भी सारे पढ़े लिखे लोग बैठे, कोई हमारे खिलाफ तो कोई भी नहीं है बैठा हुआ।
ये पोस्ट ऑफ नोट्स ये तो पेशेंट अपने साथ ले जाता है ना
सर, आपके अपने पास होना चाहिए। आपको पता है कि अवेस्टिन के जिन लोगों के साथ इशू है, उन्होंने कहा जी रिकॉर्ड दिखाओ। इसको आपने कहा जी सितंबर की 19 तारीख को दिखाओ सितंबर 19 का आपका थिएटर का रिकॉर्ड रजिस्टर किधर है, ऑपरेटिंग। आपको अंदर थिएटर में रजिस्टर बनाना पड़ेगा अपना, और पोस्ट ऑफ नोट्स का आप फाइल बनाओ अपने पास एक
अलग पेशेंट की अलग।
सर अगर पेशेंट के पास, आपके पास ऑपरेटिव नोट्स यार सरकारी अस्पताल में आपके पास होते नहीं, अपने पास भी तो होते हैं जो आप सर्जिकल नोट्स लिखते हो,
आप इंट्रा नोट्स लिख लेते हैं जो आप प्रोसीजर करते हैं, पोस्ट ऑफ नोट्स।
तो वही पोस्ट ऑफ नोट्स बेटा वही होंगे ना जो डिस्चार्ज कार्ड पे वही तो लिखा होता है ना, ऑपरेशन का नाम।
कार्ड एक पेशेंट को मिलता है, उसकी एक कॉपी बना ले।
आप जो पॉइंट आउट कर रहे हैं आपके पास अपना रिकॉर्ड होना चाहिए।
सर लेकिन आपने आज एंटी-VEGF लगा दिया है और वो कल आता है
बाय डिफॉल्ट आपके पास लिखा हो कि 25 नवंबर को इसको मैंने एंटी-VEGF लगाया राइट आई में, समझ गए मेरी बात। और जो आपका उसका प्रोसीजर पेज है वो आपके पास अपने पास रख लो, पेशेंट के ना दो। इवन अगर कोई केस होता भी है तो वो पेशेंट खुद प्रेजेंट करता है
एक पेशेंट है इधर का एरिया का, उसने पेशेंट ने खुद प्रेजेंट किया कि जी ये मुझे डॉक्टर साहब ने लिख के दिया था और आप पढ़ ले। उस डॉक्टर साहब ने लिख के दिया था कि वीएन विल इम्प्रूव, और वीएन डिडंट इम्प्रूव नाउ। तो इसलिए ये सारी चीजें। एक आखिरी चीज मैं कर दूं कि अगर आपका ये वाला इशू है, ये अब सबसे बड़ा जो है वो डॉक्टर पे है। अभी सारे हम बच गए हैं क्योंकि डिस्पेंसर कोई और था, डिस्पेंसिंग वाला बंदा वो मान गया है और उसने अपने सर पे ले लिया और हम बच जाएंगे इंशाल्लाह। लेकिन अगली दफा डॉक्टर क्योंकि खुद डिस्पेंस करेगा तो सबसे अच्छा ये कि दोनों कंसेंट फॉर्म करें और डिस्पेंस तब करें जब आपको श्योर हो कि जी मैं इसकी अच्छी डिस्पेंसिंग करने के अहल हूं और मेरे पास बल्क जो है मैं उसको डील कर लेता हूं। लेकिन मेरा अपना, मैं कासम से भी, खान साहब से भी, हम कल भी 7 घंटे गाड़ी में यही डिस्कस करते आए हैं कि मतलब ये एक मुश्किल हो गया है काम और ना करने वाली बात सी हो गई है प्राइवेट सेक्टर में। गवर्नमेंट सेक्टर में तो देखें हम वायल खरीद के 40 मरीज को लगा के फेंक देंगे और उधर होता भी है कुछ तो इतना ज्यादा नहीं क्योंकि कंसेंट फॉर्म वगैरह का रूटीन में बना होता है। प्राइवेट देखो सर, अगर आप हाथ उठा के देखें कितने लोग कंसेंट फॉर्म लेते हो आप एंटी-VEGF से पहले, मतलब हाँ वो थोड़ा, और कितने लोग एंट्री करते हैं रजिस्टर में,
लेकिन प्रोसीजर नहीं लिखा,
मतलब वही ना। तो वो सर उन्होंने कहा है कि ये इंट्रा ऑपरेटिव प्रोसीजर है। आकाश से पूछे हेल्थ केयर में, कहते हैं ये किधर लगाते हो आप? आंख के बाहर लगाते हो, नीचे अंदर लगाते हैं? तो कहता है बाकी जो पर्दे का ऑपरेशन वो भी अंदर करते हो, तो वो लिखते नहीं हो, जी लिखते हैं, तो इसका क्यों नहीं लिखते, कैसे लगाया?
वो नॉन डॉक्टर
नहीं सर, वो डॉक्टर ही है, उनके पास एक क्यू कार्ड बना हुआ है, वो उसी तरह ही सवाल पूछते हैं।
एक क्वेश्चन ये है कि जो हम आइडिया लगाते हैं, आइडिया के जो लोग 3 डोजेस बनाते हैं,
हाँ जी ठीक है,
वो भी ऑफ लेवल यूज होगा या सिंगल डोज कंसीडर?
नहीं, आइडिया वालों की लिटरेचर रिकमेंडेशंस हैं कि आप उससे 3 डोजेस बना सकते हैं।
वो अगर आप उनमें आप इशू होता तो वो आपकी
ये लिटरेचर रिकमेंडेशंस हैं। ड्रैप वालों
आइडिया तो
कंपनी तो रिकमेंड नहीं करती ना, लेकिन आप उसमें से 3 डोजेस,
लेकिन कहाँ किसने इजाजत दी है?
ये है, मैं आपको दे दूंगा, ये मैंने पढ़ा है, क्योंकि इसमें से 3 डोजेस आप बना सकते हो। वो जो अपनी लुसेंटिस है उसमें से नहीं बनती,
क्योंकि इस पे ना कंपनीज के आखन बनाता है,
की रिस्पांसिबिलिटी नहीं है,
कंपनीज ने स्पेशली लिखवाया आखन से कि we are not responsible, we are only, it's for only single use।
डिस्पेंसिंग का
क्योंकि ये कंपनीज कभी भी ये
देखिए, डिस्पेंसिंग जो है आपने से 2 डोजेस बनानी, 3 डोजेस बनानी, जो बनाना है इसका रिस्पॉन्सिबल डिस्पेंसर ने होना है, इसका कंपनी ने किसी सूरत भी रिस्पॉन्सिबल नहीं है।
डिस्पेंसिंग अलाउ है,
डिस्पेंसिंग पे कोई प्रॉब्लम नहीं।
दूसरा एक चीज
भाई फर्क है डिस्पेंसिंग क्योंकि घुसा हूं उसमें से। डिस्पेंसिंग का मतलब है कि आपके थिएटर से बाहर नहीं जानी, बेचनी नहीं है, आप
नहीं थिएटर के अंदर आप
कर सकते हो डिस्पेंसिंग।
दूसरा बायलैटरल साइमल्टेनियस,
ये नहीं, ये बात डिस्कस हुई थी, मैं बताऊं ना, जो मीटिंग थी जनरल साहब,
सिंगल लाइन
मैं मीटिंग में ये बात डिस्कस हुई थी कि आप लोग ज्यादा टीके बनाते हो, तो मैंने ये बात की थी कि जो आइलिया है मैं उससे 3 टीके बनाता हूँ एक ही वायल से, वेस्टिन से मैं 62 टीके बनाता हूँ। तो उन्होंने कहा था इस पे कोई नहीं है, आप एक दवाई है उसकी डोज पूरी कर रहे हो ना, या तो ना जो आइलिया है उसके अंदर 1.5 मिलीग्राम ना हो, दे है 1.9 मिलीग्राम ml, 1.9 ml, ठीक है ना, वो मतलब 3.25 डोजे आराम से बन जाती है डेड स्पेस खत्म करके। तो उन्होंने कहा था जी उससे आप 62 डोजे, वेस्टिन से 62 टीके बनते हैं, इससे आप 3 बना लगते हो, लेकिन अब उसको बना के बेचना या थिएटर से बाहर लेके जाना वो गलत है। जो वायल उस थिएटर में खुलेगी उसी में ही लगेगी।
अच्छा बायलैटरल का,
बायलैटरल की डिस्कशन कोई नहीं है यार दुनिया में, जो मैंने इस पे मेटा एनालिसिस लिखा हुआ है बायलैटरल का, दुनिया में इसका कोई साबित नहीं हो पाया कि बायलैटरल अच्छी है कि सिंगल अच्छी है। यार ये कुछ नहीं कह रहा है, इस बारे में डिस्कशन
कोई एडिशनल रिस्क
नहीं है, मैं वही कह रहा हूँ, कोई
प्रिकॉशंस की तरह लें, जिस तरह एक आप करते हैं क्लीन करें, आप स्क्रब हो, वो चीजें करें।
एक चीज जो मेरे ख्याल में हर जगह मिस हो जाती है ना, वो ये है कि देखिए ये पाकिस्तान में जो रानी विजुमेट है ना, ये टेट्रेजरा के नाम से, इंडिया में एक्सेंट्रिक्स के नाम से, और आप हैरान होंगे, मेरे ख्याल में, मुझे एग्जैक्टली नॉट श्योर, लेकिन एक्सेंट्रिक्स की जो कीमत है वो इंडियन रुपीस में कोई 4000 तक, यानी मतलब
बायोसिमिलर होगा
जी, बायोसिमिलर नहीं है, एक्सेंट्रिक
नहीं, वो कंपनी नहीं, और कंपनी ने बनाई है। वो इन कंपनीवाइटिस की नहीं है।
एक्सेंट्रिक्स बायोसिमिलर नहीं है, वो ऐसे ही है जैसे
वही चीज है लेकिन कंपनी और पेटेंट खत्म हो गया होगा।
मतलब मेरा ये है कि देखें कोई ऐसी बॉडी होनी चाहिए या पीवीआरएस हो या ओएसपी हो कि जो ड्रेप के साथ या जो कंपनीज हैं जो प्रोड्यूस कर रही हैं उनके साथ निगोशिएशन करे कीमत पर। क्योंकि देखें अगर आपके पास रानीविजुमैब या इवन आइडिया आपके अफोर्डेबल रेंज में आ जाता है तो आप क्यों एवेस्टिन यूज करेंगे?
सर मैं
क्यों
इसकी
इतना
एक अर्ज
खतरा
करूं,
लेंगे?
2014 में हमने अवारी में लुसेंटिस की जो खान साहब भी थे जब लुसेंटिस आया था उसकी कीमत उस वक्त वो 50,000 रुपए ला रहे थे, मैं आपको सच बता रहा हूँ 50,000 उस वक्त थी, हम उसको 26,000 पे लेके आए थे 28 समथिंग पे। नहीं लुसेंटिस की
एक्सपेंसिव लॉन्च हुई थी
वो लॉन्च हमने लाहौर में सब ने बैठे, हमने उनके मेन डीलर को बुलाया और हम इसको 50 से 26-27,000 रुपए 27,000 रुपए का 28,000 रुपए का ये मिलता रहा है हमें। अब मसला ये है कि अब जो नई कंपनीज आ रही हैं जैसे भाई बिस्मो ने आना है वो अभी से कह रहे हैं कि वी विल बी नियर द आइडिया मे बी लिटिल बिट अहेड, समझ नहीं आई, लेकिन वो क्लेम क्या कर रहे हैं कि इसका गैप पीरियड ज्यादा है, कम इंजेक्शन लगाएंगे। सर इसमें देखे कोई भी जब तक हेल्थ मिनिस्ट्री नहीं इन्वॉल्व होगी ना, ये हमारी सोसाइटीज का इम्पैक्ट फैक्टर नहीं है। हम जो ओएसपी वगैरह वीआर सोसाइटीज है ना, जब तक किसी बंदे के अपने पर्सनल लिंक उस वक्त के फेडरल हेल्थ मिनिस्टर के साथ नहीं होंगे,
ग्राउंड रियलिटीज है ना बैकग्राउंड, वो तो आपके सामने है सब कुछ।
मुश्किल है सर, बड़ा मुश्किल हुआ है।
क्या इंटरेस्ट है, कोई बॉडी होनी चाहिए। आप देखें ही अल्कॉन कंपनी जो आईओएल्स दे रही है पाकिस्तान को भी दे रही है और
बाकी दुनिया में
भी दे रही है। इंडिया में कीमतें आधी से भी कम है पाकिस्तान में जो
बिकॉज दे आर मैन्युफैक्चरर, दे हैव अ बिग मार्केट।
अब तो वैसे अल्कोहल खत्म हो गया ना, इंडिपेंडेंट कर रही है उसके साथ आप कर रही है।
अब सर देखिए मैं आपको बताता हूँ इंडिया में इस वक्त कुछ 550 के करीब कॉन्सुलेशन है, 550 के करीब कॉन्सुलेशन यूनिट सेल आउट। वो कहता तेरे मुल्क में 13 है, मैं क्या तुम लोगों को बेनिफिट दूं?
चलिए इसको कंक्लूड करते हैं।
थैंक यू। हाँ जी
इब्रार साहब जस्ट वांटेड टू से
लास्ट आपने बताया कि डिस्पेंसिंग में एक दिन में आप 40 इंजेक्शन बना लें और लगा दें, वही इंजेक्शन आप स्टोर कर सकते हैं?
नहीं सर, कोई स्टोरेज, ट्रांसपोर्ट स्टोरेज नथिंग, while opened you dispensed it and disposed it of, that's all.
थैंक यू।
एक और बात इसमें जस्ट
मतलब है कि ये भी मतलब आप बताएं कि अननेसेसरी इंजेक्शन भी नहीं लगा।
सर वो कम हो गए ना, अब जो पहले जनरल ऑफ्थल्मोलॉजिस्ट था, जनरल
आपको मैं बताऊं, पेशेंट सर को मैंने कहा कि आपको इंजेक्शन कोई फायदा नहीं देता।
हाँ जी।
दैट पेशेंट वेंट टू इस्लामाबाद,
उठी का लग गया
वो पैन ऑफ्थल्माइटिस के साथ हो गया। तो मतलब ये है
सर हमारे पंजाब में 50% इंजेक्शन कम हो गया है। जो जनरल ऑफ्थल्मोलॉजी ऐसे आता था ना, तुम्हें शुगर है और ना देखा नहीं था 3 इंजेक्शन है, वो बहुत कम हो गया। प्रोफिलैक्टिक और ऐसे ही डायबिटीज को लग रहे थे, वो बहुत कम हो गया इस वजह से।
अभी तो लग ही नहीं रहा था
नहीं वो लुसेंटिस तक जाने वाला तो है ही।
Now, just coming to the last, that is the panel discussion. We were just discussing the few scenarios briefly and quickly, as we are short of time. The panelists for this discussion with us are Professor Sanalajan Sir, Professor Bilishad Sir, Professor Naveed Qureshi Sir, and anyone else can also join. The Professor Naveed Qureshi Sir, and
पीछे बैठे राजेश।
ओके
काफी देर से पीछे बैठे।
आप यहाँ पे जो लेते हैं वो एंटी-VEGF वाला ले रहे हो कि दूसरा कोई ले रहे हो?
ऑन्कोलॉजिस्ट हमारे क्लिनिक है तो उनके थ्रू। लेकिन मैं जस्ट टू कंक्लूड आपका जो है ना, मैं 2 बातें करना चाहता था। बेसिकली ये ऑफ लेबल यूज में आपको अगर आपकी बायर भी यही मसला है, इंश्योरेंस वाले फिर कवर नहीं करते। इधर तो सब कुछ आपके सर ही आता है ना, इंश्योरेंस यूजुअली होती नहीं। तो ये जो आपने प्रोटोकॉल्स थोड़े से आपने एक तो ये कि प्रॉपर कंसेंट फॉर्म हो, सेकंड ये कि प्रोसीजर उसके साथ वो शीट भी हो, और साथ उसके साथ साथ जो हम कह रहे हैं ना कि इंजेक्शन आए उसी दिन खुला हो और उसी दिन वो इंजेक्शन लगाओ, तो ये आप सेफ उसमें आ जाएंगे। चार पॉइंट जहन में रखने हैं।
The first scenario is that we come across patients who have been done excessive PRP lasers. कोई जगह लेजर के लिए बची नहीं होती, लेकिन still you get fresh bleed in those patients. So the question is whether you are going to deal this patient again with anti-VEGF or the treatment is PPV. Ideally, the treatment is vitrectomy. But is there any role for repeated anti-VEGF injection? And if you have treated this patient, how much anti-VEGF usually you treat to control bleed?
I think this is the situation that patient has a vitreous hemorrhage more dense on the optic nerve and slightly fading away from the macula. And we can see I can see some fibrous tissue as well. So if there is some traction with the amount of PRP done, I think there shouldn't be any residual NVEs or NVDs. But if there are some traction, maybe with the movement of those fractional bands, the patient has developed this hemorrhage. I think depending on the other eye, what's the condition of the other eye? If the other eye is good or has good pain, I would like to wait for some time in this patient vitreous hemorrhage clears. Then you see what is the pathology, where the hemorrhage comes from. Because if you give anti-VEGF in a band, if he has fractional band, even that's not going to help because it's not going to have some fractional retinal detachment. But we have to look at the macula.
In case there is no traction at all, and there is minimal hemorrhage, and you see that there is some proliferation going on, but there is no place for laser. So you are going to wait, or you are going to inject for the moment?
I'll just wait.
You don't inject.
If the other eye is good, I'll wait for 6 weeks, and then I'll see.
My comments would be little bit different because now hemorrhage is there and this is from the new vessels. We see it or we don't see it, but there are some new vessels which are bleeding. In this eye, because pattern laser नहीं हुआ, पुराना इसमें काफी आपको fill in space मिल जाएगा. So first thing I would go for further laser and augment PRP. If there is no fibrosis, because in this picture, as Nadeem pointed out, there is suspicion of some fibrosis at disc and around. So if there is no fibrosis, I can inject also.
And how much will you?
And then observe. I would observe if the hemorrhage is just resolves, there are new vessels which are also resolved. If they are still new vessels, then you can inject again, or if there is a space, you can further aid your laser.
ये पेशेंट फिर कुछ टाइम बाद फिर दोबारा आती है रीब्लीड के साथ कि नहीं, बस एक दफा आपने रिग्रेस हो गए एंटी-VEGF के साथ, तो बस मेरे नहीं होते।
उसमें ये बहुत इम्पोर्टेंट है कि आपका जो डायबिटिक और ग्लाइसेमिक और रिस्क फैक्टर कंट्रोल है ना, वो बड़ा इम्पोर्टेंट है। वो आपने चेक करना है और उसको आगे लेके, लेकिन साथ साथ ये दो ऑप्शन आपके साथ है।
अच्छा, इसका सॉरी ऐड करना चाहूँ, इसमें आप OCT आप should must do OCT. Even with this hemorrhages you can get even with this kind of OCT you can get a good posterior pole information. If there is some ERM and there is some traction element, then the answer is first to inject and then go for the surgery. If there is no ERM, there is no traction, then again give injection and wait for the hemorrhage to resolve. And then some areas under the hemorrhage maybe it's missed, the laser is not properly done. Then you should go for the laser and use ultra wide field lenses for the periphery as well. Sometimes we see the posterior, even mid periphery, till equator there is good laser, but the periphery is missing. So while doing peripheral extensive PRP, these new vessels regress and you can save the surgery. But in that case, you can avoid surgery.
If there are miniatures visible in the disc or near the disc or in the retina, then we should go for VG. If not, they are not visible, then this may be a PVD after this so much laser treatment, and it means that the patient still needs anti-VEGF or laser because the new vessels are there. So OCT, anti-VEGF, and laser.
I've been through similar kind of scenario. A problem is the patient can have a kidney disease also. अब मैंने एक पेशेंट था, उसको खाली स्पेक्ट्रम किया तो वहाँ सब कंडक्टेबल ब्लड वेसल ब्लीड कर चुके थे। इस क्रेटिनिन वाज 3.1। इन पेशेंट का क्रेटिनिन लेवल और ब्लड यूरिया लेवल चेक करें, अगर वो ज़्यादा उसको कंट्रोल करें, दे माइट नॉट कम नेक्स्ट।
ये पेशेंट के दफा ब्लड थिनर्स पे भी होते हैं।
ब्लड थिनर्स पे भी होते हैं, इनका ब्लड प्रेशर कंट्रोल नहीं होता, अभी उसका केस, तो I think that case you wait and see.
One comment I would like to, I think there is a definitely intentional fibrosis there, and that these are the cases in which recurrent bleed will happen. The best thing is you go for it.
Okay, now this scenario was discussed, but just to any new point to add, the patient is a PDR patient and wants to save his field, he doesn't want to have this sort of laser. So, have you managed this patient in your real world with anti-VEGF, the PDR management? And what were the outcomes and how long did you inject anti-VEGF in those patients to control PDR?
I mean, you are saying that if you don't do the PRP,
Yes.
You will manage. Obviously, if he's a young, you can go for the anti-VEGF.
मेरा सर ये कि आपने अगर मैनेज किए हैं सिर्फ एंटी-VEGF से PDR को तो आपने कितनी लगाई और क्या फॉलोअप था उसका?
मैं जो relatively young है उनमें anti-VEGF पे ही जाता हूँ, क्योंकि आपका जितना मर्जी PRP कर लो, उनमें ब्लीड होता ही होता है कुछ अरसे के बाद।
इसमें एंटी-VEGF का प्रोटोकॉल क्या है? मतलब आप लोडिंग डोज देते हैं नहीं PRP देते हैं किस तरह फॉलो?
I see when there is no NVD or NVE, I stop myself and then I follow it monthly.
Systemic control अच्छा है.
फिर अगर डेवलप होते हैं
डेवलप होता फिर मैं 3 इंजेक्शन
It has to be a very meticulous examination on the follow because if you miss a one और प्रोनाटा पे हम चले गए और
सर जब PDR रिग्रेस होता है ना तो दे आर वेरी क्लियर साइंस, जब ये रिकरेंस होगी तो आपको बड़ी जल्दी पिक हो जाते हैं उसमें। फिर अर्ली PDR को पिक करना मे बी सम चैलेंजिंग समटाइम्स, बट when there is a PDR and you have regressed that PDR and you know all the focal points जहाँ से ये होना है बात, and then it's very easy. So क्योंकि young patients में when they are 40, 45, they are very juicy vessels. Within week उनकी डिस्क के ऊपर से पूरा एक फ्राग उठ के विट्रियस तक आया होता है and they are very difficult.
जी सर.
I think we have discussed in my talk, according to Clarity trial, we give the aflibercept after every 4 months, and then after 2 years, the patient did not progress to the severity of the disease. So, if the patient demand is driver, night watchman, sportsman, we should consider aflibercept.
Depending he controls systemically within 3 months.
उन्हें बताया कि अपने HbA1c को 6 से नीचे रखना है।
एक चीज I would like to mention, इसमें ये जो young patients है ना, इसमें थोड़ा और elaborate करना होगा। अगर ये insulin dependent diabetics है ना, then it's a very difficult scenario then just to treat the patient with anti-VEGFs.
और इंसुलिन इज द बेस्ट फॉर अ ट्रीटमेंट। जिनमें पॉलीफेज चले गए ना उनको गोलियों पे वो भी कंट्रोल, आई थिंक दे शुड बी शिफ्टेड ऑन इंसुलिन, क्योंकि इंसुलिन के हम कई ऐसे फंक्शन जो हमें नहीं पता, सो आई थिंक दे शुड बी शिफ्टेड ऑन इंसुलिन।
Just a quick comment. लेजर भी जो है ना बेसिकली जब आप PRP कर रहे थे इट्स वेरी हैवी लेजर. आप एक तो एक स्पॉट का वो रखना चाहिए, दूसरा नेजली एंड टेम्परली यू लीव द एरिया. तो उसमें इवन ड्राइविंग में यूके में भी यूज्ड टू डू लेजर ड्राइविंग, दे वर अलाउड सॉर्ट ऑफ थिंग. ऐसा कोई इतना इशू आता नहीं है. प्रॉब्लम सिर्फ ये आ जाती है इनका लॉन्ग टर्म फॉलोअप, क्योंकि अभी तक मुझे लगता है ऐसा नहीं है कि प्रोलिफरेटिव डिजीज खत्म हो गई हो. लेजर में भी प्रीटी श्योर हो जाते हैं आपने अच्छी लेजर कर दी है, दे आर नॉट गोइंग टू, अगर जो इस तरह फॉलोअप्स नहीं करेंगे कई पेशेंट नहीं आ रहे होते. और यंग्स में बहुत चांसेस होते हैं, खासतौर पर जिस तरह हम बात कर रहे हैं कि इंसुलिन डिपेंडेंट है, टाइप 1 जो है उनमें ज्यादा रिस्क यही होगा कि बहुत वर्स कंडीशन में आएंगे. आई एम डीलिंग विद 2-3 पेशेंट्स ऑफ पेशावर, हॉरिबल कंडीशन उसकी, मतलब मैं देख सकता हूं. फिर
किडनी हो गया,
किडनीज की क्या वो तो आपके पास है. सिस्टमिक कंट्रोल इज इंपॉर्टेंट, बट फॉलोअप आपका फिर लाइफ लॉन्ग ही रखना, उनका मतलब आपको बड़ा क्लोज रखना पड़ेगा, जिसमें आप सिर्फ
और यूजुअली डू नॉट हैव ब्लाइंडनेस, दे डाई बिफोर दैट बिकॉज़ ऑफ द किडनी प्रॉब्लम.
मैं इस चीज़ को सिर्फ इस तरह से कहता हूँ कि मैं अभी ऑलमोस्ट 40 साल हो गए करने के, मेरे पास इंसुलिन डिपेंडेंट जितने हैं कोई मेरा ख्याल है लाइफ टाइम फॉलोअप तो कोई होता नहीं. तो ये आप जहाँ मर्जी कर लेंगे, आप तो लॉन्ग एक ना एक वक्त में आपको लेजर करना पड़ेगा. ये आप भूल जाएं कि आपके पास इतना लंबा होता है. और आपको ये मतलब ऑल ऑफ अस आर विट्रोरेटिव सर्जन, और आपको पता ही है कि जो एक इंसुलिन डिपेंडेंट यंग बंदे के साथ लेजर करना, सर्जरी करना बहुत डिफिकल्ट इट इज. एंड वी नो दिस थिंग कि जिसके साथ आपने PRP कर दिया होता है उसमें कोई लेजर और उसकी विटेक्टमी करना इज मच कंपैरेटिवली इजी. आई थिंक सो इन रियल टाइम सिनेरियो इवन इन द वेस्टर्न वर्ल्ड में भी ना कोई ऐसी बात मैंने आज तक किसी रेटिना मीटिंग में नहीं सुनी कि जी पीडीआर को सिर्फ आप इंजेक्शन लगाएं और वो ठीक हो जाएगा। ये मैंने आज तक नहीं सुना, किसी ने सुनी हुई तो मुझे बता दें। दूसरी बात जो सबसे मुझे मैं आई विल वाउच विद व्हाट आमिर अवान ने कहा कि अगेन जो है ना वी हैव टू गो बैक टू ड्राइंग बोर्ड कि हाउ टू डू अ लेजर। अनफॉर्चुनेटली जब से फोटोकोएगुलेशन जब से खत्म हुई, जब से इंजेक्शन आया, व्हाट वी हैव डन इज वी हैव फॉरगॉटन हाउ टू गिव अ लेजर, how to do a grid, how to do a focal, how to do a proper PRP and ये करते रहे हम। वो मैं इंडियन की बात कर रहा हूँ, उस ज़माने में हम आर्गन लेज़र आर्गन करते थे, उससे पहले हम क्रिप्टॉन लेज़र के साथ हम करते थे, उसके साथ बंदों को वो अलाउ करते थे कि ड्राइविंग लाइसेंस ले सकते हो। तो दैट मीन्स कि इट इज़ नॉट दैट मच ऑफ अ प्रॉब्लम एज कम्पेयर टू जिसको हमने हाई बना दिया बिकॉज जस्ट बिकॉज इट्स मोर ऑफ अ लेजीनेस कि जी हम उस चीज़ को छोड़ रहे हैं। आई थिंक सो we have to exam में भी मैं भी करने लगा हूँ कि जी we should make sure कि हम फोटो
लेजर करवाइए
And the next scenario is
एक थोड़ा सा just a second, अभी जो न्यू लेजर्स आ गई है ना पैटर्न लेजर, उसके साथ जो स्पॉट साइज जो है ना वो जो विद द पैसेज ऑफ टाइम आपका स्कार साइज बड़ा हो जाता था, जो सिंगल स्पॉट जो लेजर होती थी और ये अभी जो मल्टी स्पॉट आ गई हैं दे आर वेरी इफेक्टिव और ये इंक्रीज नहीं करती हैं। मतलब आप देखें कोई अभी जो हम 2-3 साल से ये लगा रहे हैं मल्टी स्पॉट लेजर एंड दे डोंट एक्चुअली एक्सपैंड द स्कार साइज, तो ये बड़े मतलब अरसे तक ये रहते हैं और विजुअल फील्ड भी प्रिजर्व रहते हैं क्योंकि आपका प्रीसाइज होता है गैप इन बिटवीन द लेजर स्पॉट्स।
आपको सेशन ज्यादा करने पड़ते हैं, you have to repeat the session.
I remember in good old days we used to have this xenon photocoagulator. And the xenon photocoagulator, and I used to treat the retinoblastoma with xenon photocoagulator. And the size was so big. Later on,
the next scenario is patient presenting with the PDR and DME is a treatment naive patient, first time presenting blood, the universal hemisphere on the disc and edema. So what will be the management plan or the treatment of the gluten in this patient? How much Avastins or anti-VEGF are you going to inject and when are you going to do laser in this patient? 3rd month, 4th month, direct straight away, sir?
ये पीडीआर में डीएमई है ना, तो कोई
These are the patients that need a multifactorial regime like Avastin or IDR or any anti-VEGF. And if you look at the arrow which is pointing, there is a succinate. So far, this can be, it's away from the center of the food almost more than 400 micron. So
NVEs बनी हुई हैं
और edema center involving है।
हाँ, तो the very center can be used with the near the macula with a light laser.
इसके आप PRP कब करेंगे सर? कितने इंडिविजुअल देके फिर लेजर करेंगे?
हम पीटी के लिए 1 या 2 इंजेक्शन के बाद PRP तो मैकुलर एडिमा का वेट करें तो
वेट करेंगे
फिर नहीं फिर ये CNV से एलिवेशन इंक्रीज हो जाएंगे। So after 1 hour वो जो डिफर लेजर वाला ठीक है वो CNV 4 to 6 weeks।
देखिए एक चीज जो है वो ये भी है कि DME की एक ट्रीटमेंट PRP भी है। देखें मेन रीजन तो यही है कि VEGF लोड ज्यादा हो जाता है। सो अगर ऐसी सिनेरियो है जिसमें दोनों पैथोलॉजी एंटिटीज हैं तो यू इंजेक्ट, यू डू PRP and PRP will take care of both DME as well as PDR.
Do you inject anti-VEGF and do PRP on the same day or not? Is there any contraindication to that?
We should wait for the fluid to absorb. It is better. First we give anti-VEGF 2 or 3 loading dose, and then the new vessel, because on the new vessel you cannot directly do laser. There are multiple new vessels as well, and edema as well. So after giving loaded dose, when the fluid will dry, when you can do PR in sessions, 1 or 2 sessions or 3.
But before PRP, we should try to do grid laser and then followed by.
इसमें अगर मैं बोलूँ अगर इसमें आप अगर गौर से देखें ना तो you will find कि जी इसकी new vessel जो है very angry looking है। And what I can feel about this thing कि अगर आप इसको Avastin लगाएंगे you are going to trap ये dragging करेगा और ये आपकी it will cause more of a fiber जब ये करेगा इसमें crunch phenomena होने के ज़्यादा है। So what I would suggest to my if it's my case I would go for PRP first, periphery में जितनी कर सकता हूँ करूँगा 3-4 पेरिफ करके एक आपने मरवत ने कहा there is always तारिक ने कहा हुआ कि there was always one concept of this thing कि जी कि doing a peripheral PRP may improve the DME also इस पे भी अभी कंट्रोवर्शियल हो गया कि अभी लेटेस्ट जो पेपर्स आए हैं उनमें कह रहे हैं कि इट इज नॉट गोइंग टू बी दैट इफेक्टिव, लेकिन स्टिल आई थिंक सो इन दिस केस अगर आपकी ब्लड वेसल्स बिकॉज दे आर सो एंग्री लुकिंग, इफ आई गो जस्ट Avastin and don't do anything else, there is a possibility of a crunch phenomenon developing, kind of a crunch from now on. तो I would go for a peripheral laser जितना maximum 3-4 करके उसके बाद I would go straight with anti-VEGF और ये edema ठीक कर सकते हैं. And along with that, because this is आपका phobia है ना, so that means it's a central involving है. तो अगर ये central involving ना होता और सिर्फ periphery के होते तो I may could have gone for a grid or a.
आप PRP कितने टाइम बाद एंटी-VEGF? Sorry, PRP कितने दिनों बाद एंटी-VEGF लगेगा?
मैं 3 लगा के जब मैं देख लूँगा कि रिग्रेशन होगी है फिर मैं एंटी-VEGF लूँगा. PRP करके 3 PRP करके आफ्टर
ये एडिमा ऐसे ही रहे बस करें.
I will not worry about this. Okay. Now again I will tell you why. Because edema, even with this kind of edema, I don't know what is her vein like. It may be a very good vein, and it is 612 vein. So it is not going to cause harm because there are a lot of patients जिनके साथ है कि जब आर्टरेक्शन ठीक है तो आपको कोई ऐसी इमरजेंसी नहीं है, आप उस पेरिफेरल ट्रीटमेंट करें, सिस्टेमिक उसकी ट्रीटमेंट बाकी डायबिटिक्स वगैरह कंट्रोल करें एंड देन यू कैन गो फॉर इंजेक्शंस आल्सो.
इसका सर हमारे पास अल्ट्रा वाइड फील्ड तो एक इमेज है नहीं. वी आर सस्पेक्टिंग दिस काइंड ऑफ जो जितनी एग्रेसिव जो वेसल्स हैं, देयर इज अ पॉसिबिलिटी कि इंफीरियर रेटिनल हेमरेज, पेरिफेरल रेटिनल हेमरेजेस. So with the presence of these kind of hemorrhages, sometimes it's difficult to do PRP, effective PRP. So मेरा ये है कि इसको anti-VEGF लगा कि clear the hemorrhages, then go for the PRP. It's my
इसका PRP पहले होगी तो इसमें जो मैकुलर एडिमा है वो टाइट्रेट होगा, वो और बढ़ेगा. तो आपने पेशेंट को पहले से ये बताना है कि नेक्स्ट 2 वीक्स में आपकी विजन और डिटोरिएट होगी.
सर ये सिनेरियो बस ये लास्ट डिस्कस कर लेते हैं बस. What is the role of grid laser?
आपस में बात तो हमने कंक्लूड करनी है, हर एक अलग-अलग चीज कर रहा है.
सर सिर्फ फोकल और आजकल ग्रिड तो सीन से आउट हो गया, लेकिन आजकल भी अगर कोई ग्रिड लगाते हैं तो क्या इंडिकेशन है कि ग्रिड लेजर पे जा रहा है?
There is diffuse edema, go for grid. We are doing grid almost.
So we are treating diffuse edema with anti-VEGF. So when are you going to think that it's I'm going to
My indication for grid will be the patient who cannot come for regular injections. Cost is, cost matter for that patient. So in such patient, I would go for grid laser.
और ग्रिड लेजर में भी वो कहते हैं कि आप सब थ्रेशोल्ड ग्रिड लेजर करें, उसमें मल्टीपल सेशंस करें. दैट विल रिड्यूस योर बर्डन ऑफ एंटी-VEGF. लगाने पड़ेंगे लेकिन उसके अंदर गैप आपका ज़्यादा होता जाता है. यू नीड टू गिव अब ये ग्रिड लेजर है
सर पल्स मोड करना है.
Like in grid laser में you should go for the C or inverse C. Papular macular bundle तो ना हो रहा है.
Thank you, sir. That concludes the panel discussion at the Anti-VEGF Symposium. There was other predictive scenarios, but we are just running short of time.
अगर बैठे तो एक दिन तो हमें आपस में
आज इतना anti-VEGF हो गया है, अगले 6 महीने के लिए काफी है. नहीं सर, कुछ है 2 काम करने पड़े.
Just the concluding ceremony now, we will be awarding the shields and certificates to the speakers. I would request the Honorable Professor Jastan Sahab, General Nazar Sahab, President TVLS, Professor Sanala Jan Sahab, and Professor
ग्रिड मल्टीमीडिया ऑप्शन तकरीबन आउट हो गया. ग्रिड जो इस तरह से ये जो रिंग बना देते हैं
सब थ्रेशोल्ड आ गया.
वो तो हाँ सब थ्रेशोल्ड का मैकेनिज्म क्या है, इसका मैकेनिज्म पता ही करते हैं. लेकिन सर वो ये वाला लेजर जो है तो काफी डैमेज कर देता था. पहले भी देखिए
we present the speaker sheet and certificate to Professor General Nazar Sahab. Next is Professor Ravi Amir Awali.
सर सामने देखिएगा.
Professor Dr. Hussain Ahmed Khakan. ऐसा लग रहा है कि केमिस्ट्री लगाने में बिल्कुल पीवी जैसा हो गया।
बैरिस्टर करते हैं।
ये जो 25 खर्चे हुए हैं ना उनसे पूछो वो किस हिसाब में है। रोज 6 पेशियां दे रहे हैं वो।
Ready, sir?
प्रोफेसर मीर ईशा सर
मीडिया की वजह से पता बहुत चलती है।
सर प्रोफेसर तारिक award to give the sheet to the Professor Professor Tariq Professor Qasim Latif sir.
मुतासरीन ए वेस्टिन
There is a small souvenir and gift from the President PVRS side from his own love and affection for the invited guests.
ये ऑफर वैलिड है एक दिन के लिए तो
Thank you.
काली वो वकीलों आई पता चले डराया किस ने
आपके लिए स्पेशल कलर कर रही है
मेरी बात
आगे हो
सर इसके बाद
आ जाओ काम कराएंगे सर
ऑफर दे बाद क्लास बाद
एसी चला गया
क्या ला
I would now request General Sahab to have few words. And afterward, I would then request the chairman, Professor Devashan Sir, to conclude the session.
Bismillahirrahmanirrahim. It has been really a very nice discussion about this anti-VEGF, and I think so. The present scenario of having all these kind of problems, I think so. I must appreciate Professor Snolla and his team to organize this kind of a seminar, which helped us to make and the guidelines for the future management of these diseases, and along with it, the issues related to or with the government and with the health authorities. In the helm of the affairs are also the drug companies, which according to their efforts and help, they are organizing seminars, and I am grateful for Bayer to help us in this regard and to pass it on the torch. One thing is there that wherever the management of any disease is concerned, there are a bit of controversies and there are a bit of discussion about this usage. But one thing should be clear to all the participants over here, that these treatments are mainstay for the diseases which we have talked about. Use and how to use them, and the modalities may be different, but their uses are very important. With these words, I'm once again grateful to Professor Snolla to ask us to come over here, and it's always been an honor coming to Peshawar. Thank you.
Bismillahirrahmanirrahim. I would just like to thank, congratulations to Professor Sanallah Jan and his team for organizing this really very academic and very interesting session. And I would like to welcome all the legends of retina coming from all different parts of the country. Professor Tariq Marwat mentioned about some history of the West End. I would like just to say a few words about the history of the retinal surgery. I've been trained in England in Moorfield and Guy's Hospital in London. At that time, you see the retinal surgery was doing at that time when we used to operate on a retinal surgery patient. It used to take 6 to 7 hours. And when the patient was lying on the bed, we used to put sandbags to his, so that he shouldn't move his head. And post-operatively, we used to give him this pinhole glasses so that he shouldn't move his eyes and so on. Now things are changing now, as you can see. And in Moorfield, Mr. Faison, when he introduced this indirect ophthalmoscope, then the things become much easier instead of direct ophthalmoscope, and it was taking much less time. When we came back to Pakistan in the 70s and early 80s, we were doing this, we were general ophthalmologists, Professor Dawood and myself, we were doing this retinal surgery. And at that time, we had good results depending on the type of the patient, at what time they come. We used to do external indentation, cryo, and release of subretinal fluid. But you see the patient, when the patient comes in late stages, of course, you don't get much better time. Now, the other thing is that when I was here, when I became the dean of the faculty at College of Physicians and Surgeons in the early 20s, I realized that we should start subspecialty in ophthalmology. And at that time, Professor Farooqi was the president of the College of Physicians and Surgeons, and I asked him, sir, we want to start pilot projects in ophthalmology. And he said, what type of pilot project? So I said, I want to start with vitreoretina. And at that time, he told me that you should work on vitreoretina, what do you want? So I used to get help from the professor in Lahore, Wasif Qadri, Professor Naeem al-Haq, and I used to ask them, would you please sit with me so that I can make some sort of feasibility report regarding the FCPS in vitreoretina. And then I did the presentation to the council of the CPSP. And then there was only 9 centers at that time they were doing vitreoretina, 4 in Lahore, 4 in Karachi, 3 in Lahore, and 2 in Islamabad in the army and Al-Shifa. And we did this inspection of all these. Then there was sort of election came, and I told to Professor Farooqi so that to recognize these centers and so on. He said, "Kya jaldi hai, election ke baad karenge." I was the chief election commissioner at that time, and then he lost, and then there was nobody to look after. There was no file of all these things, so I had to take all my file myself, and I requested the Professor Mazhar to ask Chaudhry Sahab, because all the things that have been done, it's only the center has to be recognized. And that's why they started with retina. And then I started the pilot project, and then I said that the other will follow. And now you can see the oculoplastic and pediatric and so on. And I'm really glad that now so many people are taking interest, they are becoming retina. And at that time, what I suggested, that there should be no examination of the long and short case. There should be only 3 sets of examiners. One set should examine the surgical retina, the second set should examine the medical retina, and the third set should examine the logbook. If somebody is not fit, he should be deferred for 6 months. But the college said no, we had to do the long and short case as we are doing in other specialties, so they had to follow. Anyway, I don't want to take much of your time. Really, it was a wonderful session. And being a senior ophthalmologist, we have learned a lot from, so that we can see patients, so we can refer them. अभी ये ना कि एक बार अगर पेशेंट मेरे पास आ जाते हैं, मैं इसको रेफर करता हूँ रेटिनल सर्जन को, वो कहते हैं डॉक्टर साहब मैं तो आपके पास आया हूँ, आप मुझे किसी और के पास भेजते हैं। तो मैं तो कहता हूँ कि आजकल मतलब है कि ऑप्थेल्मोलॉजी में डिफरेंट स्पेशलिटीज आ गए हैं, एंड दे कैन डू मच बेटर than we were doing then in the past. Thank you very much, and I'm grateful really, and thank you.
Thank you very much, sir. I'm personally very much thankful to all the invited guest speakers who have made all the way from Lahore, Karachi, Islamabad. It's a very difficult task coming and sparing the time, the precious, valuable time, and gracing the occasion. We are very humbled, and we are
Please
very
thank
happy.
you to people who are seeing on the videos. लाहौर में देख रहे हैं काफी लोग आपको।
अच्छा सर,
वो
सामने इसकी लाइव स्ट्रीमिंग रखी।
हाँ जी, वो देख रहे हैं।
सर बहुत बहुत शुक्रिया आप लोगों का आने का, इतनी दूर से और इतनी अच्छी प्रेजेंटेशंस का। We are also thankful to the people staff for arranging और सारी arrangements करने का. Thank you for director people and also president PVRS Professor Sanal Khan साहब. And we are also thankful to the Bear Pharma कि उनके sponsorship और support के बगैर हम ये event ना कर सकते होंगे. Inshallah, looking forward to more such events. Thank you all. Lunch will be served for senior invited guests on the ground floor.
Thank you.